So firstly, I'm Sophie Frangu. I am the Associate Head for Research for the Department of Psychiatry, and I would like to welcome you to this year's annual Departmental Research Day. So we have people that are attending in person, but also people that are joining us because the event is actually streamed live. So it's a hybrid event. So in the first instance, I would like to acknowledge really our gratitude for being able to work and live within the ancestral and unceded lands of many First Nations and Indigenous peoples, as you can see on the slide. I also want to thank the members of the Scientific Planning Committee, Drs. Beasley, Tham, and Murphy, for helping shaping the program. And of course, the tireless support of our administrative team, led by Vicky Yao and Margaret Cosi. So everything that you see happening here is because of their logistic support and efforts. We'll go over our agenda very, very briefly. So I'm just doing the introduction, of course, and then we will have the State of the Department address by Dr. Laxmi, and then we will have the lightning talks, which is a series of very quick talks that are moderated by Dr. Beasley. Then there will be a bit of a break for coffee and poster viewing. And then we will come back in for our plenary session with Dr. Fusias. We have another set of lightning talks, then we will stop for lunch. And the afternoon session, we have two state-of-the-art lectures by Dr. Beasley and then by Dr. Tam. And we will close the whole day with the announcement of the awards for different members of the department and our residents. So in terms of the posters, just to mention two things. Everybody who submitted an abstract to our you cannot hear me? No. Everybody who submitted an abstract to our research day, their poster is available on the e-gallery, and this will be available after the meeting as well. So you can see the entire sort of body of submissions that we had. And we have a selected number of posters for in-person presentation, and those are in the on the poster boards in the lobby. And you will have the opportunity to interact directly with the presenters, both during the coffee break, but definitely during the lunch break. It's kind of important to pay attention to the lightning talks and the posters, because we will ask you to vote for, this is just to show you how the e-poster gallery works. So it's part of the website of the Department of Psychiatry. So you will go to the Departmental Research Day e-poster gallery, and then you will see the posters underneath. Many of the posters have actually text, a mini recording by the presenter that actually explains to you a little bit more the work that is presented in the poster. So coming back to voting, so the vote is restricted to lightning talks and the in-person posters, and it will be done through Slido. So you have to join Slido by going to www.slido. You enter the event code, and then you have two options. Option one is to vote for your preferred lightning talk and poster. And option two, which is available just for the virtual attendees, is to submit questions that then will be read aloud by the moderator. People attending in person will ask their questions directly. So the final thing that I have to mention is that next year we will be applying for CPD approval, accreditation for this particular meeting. And in preparation for that, we have to do what is called a needs assessment. So we have to get a sense of what types of things you would like for us to include in next year, not this year, next year. So this is the form, and people will be circulating the paper form to you. It takes 2 minutes to complete. And once it is completed, I would be very grateful if before you go to the coffee break, you left it on this little table here. So Nicole and Riyang and you don't have agreed to disseminate these forms. It's very important that you complete them and help them shape help us shape the program for the next year. And for the virtual attendees and other members of the department, we will send this form electronically as well. But for those that are here, we'd be grateful if you can actually fill it in now and give it back to us. So that's all from me for now. And now I would like to invite Dr. Yatham to give us the state of the department address.
Thank you, Sophia, and good morning. Let me also begin by acknowledging that our department and its distributed sites are located on traditional, ancestral, unceded territories of Squamish, Musqueam, Tsleil-Waututh, Sykes-Okanagan, Lake and Lekwungans people, and we're grateful for the opportunity to work on these lands. I also want to take this opportunity to thank Sophia, Tim, Claire, and Joe for their leadership in putting together an outstanding program for this research day. Many excellent presentations from faculty, external speakers, and also from our star trainees who will be talking about their cutting edge research. And as well, some of the other trainees will be showcasing their research in the form of posters as well. So hopefully all those will give you an idea of the breadth of research that's going on in the department. In terms of my presentation, says state of the department address, but given that this is the research day, most of what I'm going to say will pertain to what we're doing in terms of the strategic priorities that we articulated in the plan that that was implemented a couple of years ago. So this was a 5-year strategic plan, which has 4 pillars: research, education, people, and partnerships. So I'm just going to spend the next few minutes taking you through some of the things that we've accomplished over the past couple of years, mostly pertaining to the priorities that were identified under the research pillar. So this slide shows you the research funding. Historically, the average amount of funding the department has attracted was about $10 million. And you can see over the past 4 years, that number has gone up. And the year before, we almost got up to $18 million, which is a massive amount of funding for the department of the size of ours. Some of that, of course, had to do with the COVID funding, because I think the government implemented a number of programs to support COVID research. So we did get a lot of money. This year, we're still at $15 million, which is higher than the average amount the department has attracted over the years. So we're doing pretty good in terms of funding. And here you see some of the investigators that attracted funding from various funding agencies. And you can see a very long list of researchers that got funding from CIHR, which most of you know is extremely competitive and challenging to get the funding from. So we're doing pretty well. And I think almost a third of the members of the department, the academic faculty, have been able to get funding from CIHR for the last 12 months, which I think is incredibly impressive. Now, moving on to some of the things that we've accomplished in the last little while since the strategic plan has been launched. We've been able to get 3 new academic faculty positions, 1 each year, through the faculty renewal program. And of course, we also got a CRC Tier 2 position, and we've been able to get funding for a couple of positions at our distributed sites, 1 at Fraser, and that announcement will go out very soon, and 1 at Prince George, and the recruitment for that position is nearing completion. And so you can see here in terms of the progress, number of positions that are being recruited and some that are in progress. We're currently trying to recruit for a position in concurrent disorders and also in youth depression as well. From the trainees' perspective, many of you know that we have the Institute of Mental Health Marshals Program, which was established through generous donation from Marshall family, and that program has supported a number of trainees over the past few years. So far, 30 scholars have received funding and 19 fellows, and of course, the call for further fellowship positions went out this year, and those announcements will be made sometime towards the end of this month or mid-July. We also launched a stimulus grant initiative, and this was really something that we heard from clinical faculty when we consulted widely the members of the department across the province. Many clinical faculty had said that they were interested in doing research, but had no access to funding. And of course, we know it would be very challenging for clinical faculty to compete for funding from peer-reviewed funding agencies such as CIHR, and hence we implemented this funding program led by Sophia, and the first cohort of awardees was announced about a month ago, I think, and then the call for the next cohort will be going out in about 2 or 3 months. We'll also be launching the Masters in Translational Psychiatry program, and we're hoping that we would be able to take the first cohort sometime next year. In terms of some of the infrastructure that might support research, we got about $7.5 million donation from a philanthropist in North Vancouver to establish a regional ADHD clinic, a Diamond Center. So that clinic is now up and running with a psychiatrist. We are recruiting a lead for that clinic who is going to be coming from Italy, a very well-known, internationally recognized researcher in adult ADHD. So we expect that clinic to not only promote evidence-based practice, which is a challenge in the area of ADHD, but also lead a research program that will support development of new treatments and understanding of neurobiology. VCH will very soon be starting a ketamine clinic at 2 sites, UBC and also UBC Hospital and Coastal, which in addition to providing clinical treatment, will also collect research data. And we're also in the process of setting up further infrastructure to conduct studies with psychedelics such as ketamine and psilocybin and things like that. We're also partnering with the Academy of Translational Medicine to look at novel platforms, discovery biomarkers. Lots of strategic partnerships. Of course, DMCBH, we collaborate very closely. The director of the center, Lynn Raymond, as you all know, is a member of UBC Psychiatry, and we are in the process of finalizing an advert that would go out for recruitment for a data scientist position, and they'll likely be funding for more positions in the near future. Also working with the health authorities to come up with additional funding to create academic positions at the other distributed sites, because in our strategic plan, we said we need to have at least 1 academic faculty member at each of our distributed sites. So we've already got money to have a position in Prince George and also in Fraser. And now we're looking at funding to create a position at Interior Health based in Kamloops or Kelowna, and then 1 in Victoria, Vancouver Island. And just this morning, I heard that they are willing to commit $3 million towards a position. So that's going to go forward as well, which I'm very pleased about. Global partnerships, of course, we've had understanding of collaborative partnerships with a number of centers internationally. Bangalore, India is one of them, and that collaboration has led to exchange of number of fellows, and also a large clinical trial that they supported recruitment. And the work that came out of that study is going to be published in New England Journal of Medicine. That's going to come out within the next couple of months. And lots of collaborative agreements with top universities in China, and huge opportunities in terms of access to data and also opportunities for some of our fellows and residents to go to China if they're interested, to get a brief clinical experience and research experience as well. In terms of the departmental changes structure, we've established some new divisions, and we just completed the recruitment for division heads. And in the plan, of course, is to align a number of programs within the department to those divisions. And the division heads then will take a lead for supporting research, teaching, and clinical care within those divisions. So that structure will be in place, hopefully, and completed within the next few months. We are looking for a director for continuing professional development. The idea here is that, as we all know, resident training has moved towards the competence by design curriculum, and we want to make sure that as we develop CME programs for our faculty, we follow the same model as well. So we're looking for a CPD director who has the knowledge and background and credentials to be able to implement CBD curriculum for CPD as well. And we're in the process setting up a committee to recognize contributions of our faculty and trainees, because as we all know, lots of good work is being done in the department, and there are many opportunities to recognize the contributions, but at the moment, we don't have a standard process to identify who would be suitable for what award. So the idea with this committee is that that committee will monitor some of the regional, national, international awards that might be available, and then start thinking about which faculty member or a trainee might be a suitable candidate for any of those awards. So that's about research. And as I said, the strategic plan also includes other pillars: education, people, and partnerships. And in each of those areas, we've done lots of stuff. And very quickly, education-wise, we've increased the number of residency training positions, created some re-entry positions. And those are essentially for people that are already practicing. A good example might be someone who's been practicing as a family physician for a few years and decided that they're now interested in psychiatry. So we've created positions for those kinds of people to come back into residency training program, but instead of doing a full 5-year program, given their previous experience, that would be the duration of training would be reduced to 3 or 4 years, depending upon how much experience would they have. With regard to supporting people, we now have a new and refreshed website, thanks to Sophia's leadership, along with Vicky, Margaret, and many others, which looks really modern and has and easy to navigate, and has lots of things that are happening within the department. Streamlined clinical faculty appointment, which was a huge issue. Clinical faculty used to complain bitterly about the onerous process that they had to go through to apply for an appointment or promotion. So that's been fixed now. And we also have a standing academic faculty and advisory meetings. And of course, we have a strategy to address the ADI. And we've been working closely with the Faculty of Medicine, the Ready office, to implement that. And lastly, partnerships. The mandate of the academic department, of course, is to do research and education, but also we must not forget that the reason why we are in this business is ultimately to improve patient care. And so we must partner with the health authorities in the ministry, which we've been doing quite actively, and also working with the BC College to address some of the licensing barriers, because there have been huge challenges staffing some of the mental health programs within the province. So we've been working very closely with the college to address some of those barriers as well. So that is a very brief highlight of what's been happening within the department. If you are looking for more information about any of these things, have a look at the newsletter that Margaret puts together every Friday that goes out. which highlights anything that's new happening within the department. And of course, our website also has all the information. And if you're still not sure, please feel to email the department. We'll be happy to share with you any additional information that you might need. So thank you again for coming to the research day. And as I said, I think you're very much going to enjoy the presentations that are slated for today. Many are talking about some of the cutting edge research with clinical implications as well. So thank you.
So thank you for that, Dr. Yatham. So we're going to start now with our first set of lightning talks. And I would like to invite our first speaker. Our first speaker is Dr. Ruyeng Gi, and he's a research associate under the supervision of Dr. Sophia Frangu. And he'll be talking about normative modeling of brain morphometry across the lifespan using centile brain, algorithm benchmarking, and model optimization. So the lightning talks will be about 4 minutes each. And I would like to ask the audience to wait and ask their questions right at the end of all 5 speakers. And if you are watching on Zoom, please use Slido to ask questions.
Thank you, Dr. Bisley, and good morning, everyone. I'm going to talk about our team's recent work on normative modeling of brain morphometry throughout the human lifespan using our centile brain model. Using our centile brain models. In general, normative modeling is a framework for mapping how individuals deviate from a populational reference pattern. I believe you are all familiar with this method, as it is widely used in medicine, especially in pediatrics, to monitor the growth of our developing children. Essentially, it allows us to position a specific individual with regard to any measures and as compared to a normative reference population. Despite the many years of the human neuroimaging research, we still do not have normative reference values for the regional brain morphometric measures. It means that when we have a value for a specific brain morphometry, for example, if we have a hippocampus, volume of the hippocampus, at this moment, we still cannot tell if this value is within or outside this normal range. Our centile brain model is actually the first large-scale model for the normative reference values of regional brain morphometric measures. An important feature of our centile brain model is that it is based on a very large neuroimaging data set of MRI scans from over 30,000 healthy participants all over the world. And this sample is roughly equally divided by sex. And the brain morphometric measures were extracted by a software called FreeSurfer, which gives the values of cortical thickness, surface area, and the subcortical volume. Because we want our centile brain model to be empirically well supported, so we evaluated 8 different prominent algorithms in terms of their model accuracy and computational efficiency to select the best one to generate the normative model of brain morphometry. And this work is currently undergoing revision in Lancet Digital Health, and we do have a preprint version with this link and this QR code. Here, I use the volume of the left thalamus as an example to show the optimal model of this region. And also on the right-hand side, you can see the centile curves. With centile brain, you can actually check for each individual which centile is this measure on. So here, this point is a specific region. And most importantly, we focused on the usability of our central brain model. So by the entire community. So we created a very user-friendly central brain web portal, which we share all our scripts and our pre-trained models. We also have an online functionality where people can upload their data to it, and our online application will generate the division Z values from the normative mean centels, as well as the model accuracy measures for each regional brain morphometric measure. And lastly, I would like to emphasize that our central brain website guarantees the security of users' data, as we will never capture or store users' data. And please scan this QR code and take a look at our website. Thank you for your attention.
Thank you. Our next presenter is Sia Choi. Sia is an undergraduate student in behavioral neuroscience, and she did a junior honors project in my lab. She'll be talking today on levels of inhibitor proteins of the immune system in schizophrenia and bipolar disorder, SUSD4 and SES6.
All right, thank you. Hello, everyone. Like Dr. Beasley mentioned, I'm super excited to talk to you about my third year honors project that I completed on the levels of inhibitor proteins in the complement system in schizophrenia and bipolar disorder, specifically focusing on two proteins, SUSD4 and SEZ6. But first, why the complement system and what is it? And put in one sentence, it's a non-specific immune response that's completed through a cascade of enzymes. So meaning if you alter it in the beginning of the cascade, the rest of the cascade would be affected. Previously, we thought that the CNS was not affected by this and was independent because it was seen to be immune privileged. Yet we have seen in recent findings that there are complement system proteins present in the CNS. Not only that, but they play a role in synapse elimination during development and synaptic plasticity during adulthood, so postnatal organization of the synapses. In psychiatric disorder, for both schizophrenia and bipolar disorder, there are disruptions in the immune response as well as inflammation. Specifically for schizophrenia, there is abnormal activation of at least one of the pathways called the classical pathway. And there's also a genetic linkage. So one of the components, C4, their genetic variance effect on the C4a protein expression was proportional to the risk of schizophrenia. Similarly, for bipolar disorder, there are increased concentrations of C3a, C1q, C3, and C4, which were associated with inflammatory biomarkers. So this is a summary of the classical pathway that I just mentioned. And these two are our proteins of interest, called sushi domain containing 4, SUSD4, as well as seizure-related 6, SE6, and they are both inhibitors of the complement system. SUSD4 does this by interacting with the C1q subunit earlier on in the pathway, and SE6 inhibits the C3 convertase level. There has also been research in knockout mice. So for SUSD4, there is altered dendritic spine density, as well as unique morphology of the neurons in Purkinje cells. Also, there is elevated C1q levels in the brain, which is consistent with the figure above. And there are abnormal behaviors such as the motor deficits and anxiety-like behavior on tasks such as the elevated zero maze. Similarly, for SEZ6 knockout mice, there are differences in motor function, anxiety-related and depression-related behaviors, spatial memory, and again, reduced spine density. So we see that these proteins play a role in the CNS as well as behavior, but are they related to schizophrenia and bipolar disorder? And that was what we wanted to look at. And what we did was we performed quantitative RT-PCR in 93 samples of post-mortem human brain tissue. And we measured the mRNA levels of SUSD4 and SEZ6. And we compared control to schizophrenia and control to bipolar disorder for both proteins. In these graphs, you can see bipolar disorder on the left, control in the middle, and schizophrenia on the right. And we have found significantly lower values of SEZ6 mRNA in schizophrenia compared to the control, and no other significant findings in the rest of the comparisons. But this is exciting because it is consistent with previous findings on the abnormal activation of the complement system in schizophrenia, as we have seen a lower level of mRNA of the inhibitor protein. And because this was done at the mRNA level, we want to see if it translates to the protein levels. And if this relationship holds, hopefully it can be used for treatment development. For more information regarding our contact information, subject demographics, and references, you can find out the QR code here. Thank you.
Okay, I'd like to introduce our third speaker now. Our third speaker is Ms. Hayley Scheurer. She is a master's student in neuroscience in Dr. Tammy Vanderwaal's lab. And she'll be talking about movie watching as an alternative to resting state for precision psychiatric fMRI research.
There we go. All right. Hello, everyone. My name is Hayley Scheurer, and my talk is about movie fMRI as an acquisition state for functional connectivity-based precision psychiatry. This project combines two rapidly advancing fields for the first time. The first field is precision psychiatry, and this is the idea of using large amounts of data to tailor diagnosis and treatment to each individual patient. The data used for precision psychiatry can come in many forms, and here we're focusing on functional connectivity data from fMRI. This represents the functional relationship between brain regions and can contain clinically useful information. The idea of using functional connectivity for psychiatry is promising, but there's a few things that are holding the field back. We need the data to be more reliable, to be more sensitive to individual differences, and we need longer scans of higher quality. So the question becomes, how can we address these limitations? And this is where the second field comes in, which is movie fMRI. This is the idea of showing participants movies while they lay in the fMRI scanner, rather than the more common resting state where participants stare at a fixation cross. The data that we collect from movie fMRI offers some important advantages, and luckily for us, these advantages align really well with the requirements for precision psychiatry. Movie fMRI improves the reliability, the sensitivity to individual differences, and data quality and quantity. This leads us to the hypothesis that movie fMRI will provide significant advantages for FC-based precision psychiatry. To investigate this hypothesis, we focused in on three brain regions that we know to be important in psychiatry: the left dorsolateral prefrontal cortex, the right presupplementary motor area, and the left temporoparietal junction. Within each of these regions, we compared 4 measures between resting state data and movie data, 3 measures of reliability, and 1 measure of the sensitivity to individual differences. We measured reliability with the commonly used interclass correlation coefficient, as well as a multivariate generalization of this, the image interclass correlation coefficient, and also discriminability. To measure the sensitivity to individual differences, we used an identification algorithm called connectome-based fingerprinting. We found that movie data was equally as reliable as REST in the DLPFC and the pre-SMA, and that movie data was more reliable than REST in the temporoparietal junction. This is especially interesting because our 2 movie scans that we used contained different movie clips as the stimuli, so they weren't actually ideal test-retest conditions. We also found that movie data was more sensitive to individual difference than resting state data in the temporoparietal junction. These findings suggest a region-specific advantage of movie fMRI for precision psychiatry. In other words, movies may be more useful for certain applications than others, depending on which brain region you're interested in. Further research is necessary to investigate this idea in clinical populations, as well as in other brain regions, but this is a great starting point to bring these 2 fields together. This was just a short summary of the project, so if you'd like some more details, I do have a poster on the online portal. I'd like to thank you all for your attention, as well as my supervisor, Dr. Tamara Vanderwall, for all of her help, and the rest of my lab members at the Naturalistic Neuroimaging Lab.
Okay, so moving on to our next speaker, who is Ava Mameni. Ava is a master's student in neuroscience, and she's working in the lab of Dr. Todd Woodward. And she's going to be talking about whole brain networks and component cognitive processes underpinning event stimulation. Thanks.
Hi, everyone. So as Dr. Beasley mentioned, I'm going to be talking about networks that underlie memory retrieval and imagination. So with the rise of neuroimaging techniques, such as in particularly fMRI, we're able to not only visualize the brain anatomically, but we're also able to see its functional activity over time in various different tasks. fMRI doesn't measure neuronal activity directly, but it's based on the idea that as neurons fire, more blood is directed to those neurons, and fMRI captures this phenomenon. And specifically, it measures the blood oxygenation level dependent signal, or the BOLT signal. Initially, a lot of fMRI studies that looked at networks were looking at resting state networks. So in these studies, participants were placed in the scanner and they were just at rest. But task-based networks allows us to look at networks that are underlying various cognitive processes that could be measured by tasks that could be performed in fMRI. And in our study, we wanted to look at what networks are involved in imagination and recall. So in the scanner, participants were asked to either imagine a past event or imagine a future event or recall a past memory, and as well as to complete a control task. And after this phase of the task, they were asked to complete 2 surveys by button press. And we were able to find 4 different networks. The first one was the response network. And in a lot of previous studies, we found that this network shows activation when individuals have to make a motor response. And we see that in our study, when the participants have to use button press to complete the rating scales, we see a clear activation of this network. The other one that we found is the multiple demand network. And this one has been shown to be involved when individuals have to pay attention to environmentally relevant stimuli. And we see activation of this network when the task stimuli is first presented and participants have to pay attention to them to perform the task properly. The next one that we found is the maintaining internal attention network. And this one shows an activation when participants have to when they're doing the process of imagining or recalling memories. So we can see that when participants had to direct their attention more externally, it was the multiple demand network that showed activation. But when their attention had to be directed more internally, it was the maintaining network that showed activation. And the last network that we found is the default mode network, which is the most popular resting state network. And this network has been shown in the past to be to show activation when people to be involved when people are thinking about their past, present, or future. And when participants were imagining past or future events, as well as recalling past memories, this network showed a slight activation. So why is it important to study networks? Well, in a lot of psychiatric disorders, one major consequence is cognitive deficits. So understanding networks that underlie cognitive operations that are affected in psychiatric disorders can potentially allow us to have new therapeutic targets for non-pharmacological treatments, such as neuromodulation. And that's one of the long-term goals of our lab. Thank you.
Great, thank you. So our final speaker for this portion is Nicole Sanford. Dr. Sanford is a postdoctoral fellow under the supervision of Sophia Frangu, and she'll be talking about modifiable risk factors affecting brain aging in mid-age to elderly depression.
So thank you all for sticking around for my talk, and thank you, of course, to the organizers for putting this all together. I'm going to be presenting some recent findings on modifiable risk factors affecting brain aging in depression. Oh, wrong way. As a bit of background, previous studies suggest that depressive episodes may accelerate brain aging. However, tangible means of slowing brain aging, especially in depression, are unknown. Therefore, we focused on identifying modifiable risk factors that may be associated with brain aging in people both with and without a history of depression using an index known as the brain age gap estimate, or brain age. So essentially, brain age is computed by applying machine learning to predict a person's age from their neuroimaging data, and then subtracting their chronological age from their predicted age to obtain this brain age gap, where a positive value suggests that the person's brain is showing accelerated aging and the opposite for negative values. So first, we computed brain age for participants from the UK Biobank dataset, which consists of people from the general population between the ages of 44 and 82 years. We selected 896 participants with a history of depression and over 36,000 non-psychiatric controls. And in each group, explainable boosting regression was applied to identify the most important non-imaging predictors of brain age. And explainable boosting is a highly interpretable so-called glass box algorithm that has the option to detect paired interactions between features that are included in the model. In this analysis, we selected 56 features, plus we allowed for 5 interactions to emerge as additional predictors. And shown at the bottom are some examples of the features that were included, just to illustrate that the majority were actually modifiable lifestyle factors such as nutritional intake, leisure activities, physical activity, a number of other features, along with a few physical attributes. So as a first observation, looking at the top 6 predictors in each group in descending order of importance, where importance is calculated as the mean absolute partial brain age prediction, we see that the most important predictors in the control group are not the same as in participants with a history of depression. While in the control group, the model was dominated by main effects, including alcohol intake, grip strength, cereal intake, frequency of heavy do-it-yourself work, smoking status, and BMI. In contrast, in the depression group, there was a predominance of interactions with milk type most frequently consumed, along with the main effect of milk type, but with a smaller importance value. Next, I looked at the individual functions for each of these predictors, but in the interest of time, I'll just highlight 2 from the depression group. On the left is the interaction between gym participation and milk type, and on the right is the smaller main effect of milk type. In both graphs, we can see that there's a divide between drinkers of low-fat versus high-fat milk types, but the effects are completely opposite between gym goers and non-gym goers, especially with respect to drinking full cream. So whereas drinking full cream is associated with younger brain age in participants who regularly go to the gym, the opposite was true for participants who do not go to the gym. And for the main effect shown on the right, this suggests that there may be a small positive correlation between fat content and brain age. But as I mentioned, it was a smaller effect that's dependent on the other factors shown in the top right graph. So as a whole, this suggests that the relationships between lifestyle exposures and brain aging in people with a history of major depression are more complex, especially pertaining to interactions between nutrition and physical activity. So thank you for your time, and I look forward to taking your questions later.
So I'd like to invite all of the speakers to come down and we will take some questions. So we'll take some questions from the audience first. So please press your microphone if you have a question for any of the speakers.
See if I can get this working. Thank you all for your wonderful talks. I had a question actually about the movie fMRI. So my question is about the length of time for the resting state scan and whether or not there's improvement if you run scans for a longer period of time, or if you concatenate scans within a single session or across multiple days.
Yeah, so we know that both of those things affect the reliability and improve the reliability. So in general, the longer amount of data that you have, longer scan that you have, improves the reliability in both resting state and movie. And we have some more analyses that are on my poster, but didn't have time to make it in here about how reliability improves with time between movies and rest. And you can see some differences there. A lot of the time they're the same and they improve at the same rate, but in some brain regions, the rest data reaches a plateau where it no longer improves with more data, and movie can continue to improve past that point. Yeah, thanks.
So I think that's a very interesting avenue, very avenue. Approach to very structure. I was wondering, are there any clinical implications already for that type of curves, and where you may and
Sorry, can you repeat your question? I didn't hear it very well. It's not very clear. Oh, okay.
Are there any clinical implications of using normative data? I think that's what you are.
Yeah. So it's just like the baby growth chart. We're hoping to provide an initial results about how to measure your brain morphometry and project each individual's brain into that curve to calculate how much of your brain morphometry deviate from the normative values. Hopefully, it will have some clinical implications, but at this moment, I think it's probably more for the research, and for clinical usage, not ready yet.
Thanks.
Hi, I would like to ask a question to Si-Hak Choi. And I was just wondering about that sample of schizophrenia patients. What type of schizophrenia patients they were? Because there's postmortem studies that were prominent on do you know their characteristics? They were prominent more positive symptoms, or they were more cognitive impairment side of spectrum. So do you know anything about those patients?
Yeah, so the brain tissue was actually collected by Stanley Medical Research Institute, so we don't know exactly the symptoms, but from the paper that I read about that collection method, they diagnosed using DSM-4. So if they just had schizophrenia according to that, they were labeled as schizophrenia brain tissue. So I'm not sure if they showed positive, negative, or both symptoms, but they were diagnosed just using the DSM-4. Yeah.
Okay, thank you.
Thank you for the talk. I have a quick question for the last talk. It was really interesting. I think I should start probably drinking soy milk. But how much of the effects that you were seeing do you think is related to or limited by the number of participants that were involved in the study? Because I think relational correlation studies, you could get a totally different correlation when you add n to your study. For example, you might not have a significant correlation between two variables, but as you add more, it becomes significant, or vice versa.
Sure. So yeah, you're correct that maybe there can be sample-specific effects that maybe with more data we might find something a little different, more reliable. This does have the advantage that it is quite a large data set. It was just under 900 participants with a history of depression. So I think we can be fairly confident with the reliability of these results, but of course there is the possibility that there might be something different with a different data set. Does that answer your question?
Yeah.
Okay.
I guess I've got a question, I guess also for Nicole. I was wondering is there a way of shuffling the data, or do you have like a null distribution or control distributions?
Yeah, so in the training procedure, a bagging procedure is used where I believe there were 100 inner and 100 outer samples split into, I think it was 80% training, 20% testing. Sorry, lost track. What was your question? It was, yeah.
I'm just wondering if you always have the risk of like a false discovery or something. So could you, I don't know, shuffle the data or do something to say that these associations are much more significant than shuffle, kind of randomizing the associations between the lifestyle. It's all okay.
People that have used for analysis are familiar with the notion of bagging, which is actually you reshuffle the data multiple and each reshuffling is the back. And then what it actually does is looks at things and sectors which make it and identify things that are significantly more the iteration. And I think we did 100.
Yeah, it was 100 inner, 100 outer. Yeah.
So it's really robust in that respect. Because we did another sample with another question, but we didn't sample.
And yeah, so the program doesn't give p-values, but so if you look at the main effect graph with the error bars, that's the standard deviation across the training samples. So you do get a sense of reliability. And as I kind of mentioned, that was one of the smaller effects. So of course, larger errors, but it does give you a sense of the reliability of an individual feature function.
So while you're there, Nicole, I have a question on Slido for you. This is from Carl Scherer. Do you have an explanation for the fat content, why the fat content of milk might be creating the results you found? And I was quite interested in this too. Any ideas on sort of what might be going on at the molecular level in terms of fat content?
At molecular level, it's hard for me to say. I don't have any background in nutrition. I did do some follow-up reading on the literature of relationships between dairy and depression in general. Results are mixed, but there is some evidence of links between dairy and milk consumption and depression history. But it's very mixed, sort of depends on fat content, depends on whether it's fermented or non-fermented dairy. There's also, question as to whether it's the milk or is it something to do with the mineral like vitamin D or calcium. So I don't have a good answer for why fat content in particular might be important. That would be a question for a nutritionist, but there have been previous links between dairy and depression. So.
Do we have any other questions from the audience?
I've got a question for Ru Yang. It looked like you had a kind of a hole in your distribution around age 40. Is that because you've combined together like adolescent and elderly study?
We collated the data from the INIGBA lifespan group and also some public data set. So that's the limitation of the data set. But we actually, we have tested it, we divided the whole lifespan into 10 years for each decade. And we tested the model accuracy again. And the model was quite reliable across different age groups. So even though that in that part, age range, the data is not as much, but still very robust, the model.
What about longitudinal data when you start to get that with people? Can you weight that more? Because then you actually have a measure of brain aging, I guess, or brain age, I guess. No.
The normative models is the degree of deviation from the age and sex mean.
Okay.
For a region.
And very recently, we tested the reliability of our model to longitudinal data, at least three scans for each participant, and it performs very well. Yeah.
Okay, I have another question on Slido for Nicole. So this is from Clara Westwell-Roper. Thank you for your talk. One could imagine a number of socioeconomic factors and medical comorbidities that might impact one's choice of milk type. Does the model account for some of those?
I don't believe the model specifically accounts for socioeconomic factors. But yeah, there is the issue of yes, relationships between having a certain degree of wealth and being able to afford the healthier or more specialized types of foods, whole foods and soy milk. It's not specifically accounted for in the model. I don't recall there being a significant difference in, say, education level and that sort of thing between controls and depression groups, but I'd have to follow up on that.
Okay, if there's no more questions, I'd like to thank all of the speakers this morning, and we will move on and move to the break.
Just please leave your fork here for us. Thank you. This works. So, welcome back everyone from the lunch break. Before I introduce our main speaker, I just want to reiterate, we really want this form that says what you want to see for next year's meeting. So please complete it and leave it on that little table for us. It only takes 2 minutes and it's super important. So having said this, I would like to say that it's a great pleasure to welcome Dr. Fusias to our research day. Dr. Fusias is one of the people that has actually shaped treatment for psychosis from early to treatment-resistant psychosis within Canada. He is currently, about a year ago, he was in recognition of this, he was appointed the provincial clinical lead for psychosis and schizophrenia within the Mental Health and Addiction Center of Excellence for Ontario Health. He is also the chief of the schizophrenia division, the director of the Slate Family Center for Youth in Transition, and the Center of Addiction Mental Health in Toronto. So he's super busy, and we are very pleased to have him today to share some of his experience within the space of early psychosis, from evidence to practice to public health.
Thank you, Sophia. Thank you, everybody, and thank you for the invitation to be here. I haven't been in Vancouver, as I was saying to somebody, since the Olympics. It was a wonderful time back then. There's a bit of blue and white here. I will not talk about the Maple Leafs or the Blue Jays, although I do feel your pain when it comes to the Canucks. So what I thought I would do is walk you through some of the early work that we've been doing, and this, of course, is the work of many people. And take you from the sort of evolution of some of our services through to sort of informing and shaping our provincial approach when it comes to early intervention for psychotic disorders. Can everybody in the back hear me okay? Yeah, okay. Somebody wave if you can't hear me. Okay, perfect. Brief disclosure, a couple of years ago, I served on an advisory board for AbbVie, but I will not be talking about specific pharmacologic intervention. I may mention medications as a broad category, but that's it. So I wanted to do two things today. The first was to talk a bit about some of the advances in our understanding of how to deliver early psychosis intervention, and then use that as a jumping off point to talk to you about some of the work that we've been doing in building a provincial EPI program in Ontario. And so as promised, as I usually do, I start off with these two bow-tied gentlemen up on the left-hand side there, more to illustrate the fact that we need to constantly be learning and thinking about where we've come, where our understanding has come from, and also continue to evolve and push forward, and really thinking about and appreciating the fact that this is still a group of disorders and a group of syndromes, and we continue to evolve our understanding of what it is that we are dealing with and how early we need to deal with that. What we have learned is that there are a whole host of symptoms that people with schizophrenia spectrum disorders experience. One of them is psychosis, but that's only one of many. And we also know that psychosis is not specific to schizophrenia, and that a whole host of other individuals experience psychotic symptoms, including folks with mood disorders, including bipolar disorder demonstrated here, as well as major depression and a number of other neuropsychiatric illnesses. And what's important in understanding this population is to understand the dimensions of psychopathology that individuals experience, because a lot of our treatments can often be focused to a particular domain of psychopathology rather than to an illness as a whole. And so one of the other things that we've learned over time is that there are some tremendous costs when it comes to schizophrenia and schizophrenia spectrum disorders, both for the individual and for society at large. It is one of the most disabling and costly psychiatric illnesses, both in terms of human suffering and in terms of expenditure. The estimate in terms of the cost to Canada is an old estimate, now 20 years. But what's important to note here is that only 1/3 of that total cost is actually related to direct medical costs. And 2/3 of that cost is related to lost productivity. And this is in a population where, yes, there is early mortality because of a number of physical health comorbidities that this population experiences. But this is an illness that starts very early in life and disrupts people's developmental trajectory and leads to lost productivity and a reduction in their ability to connect with and engage in the normal work and school things that many other people in the population take for granted. And we've also seen that this is not an illness that generally comes on from one day to the next, although certainly that does happen for a subset of this population. But for many individuals, this is an illness that starts gradually in what has been phrased the sort of prodromal phase of this illness, with a lot of work happening to try to understand and identify that as early as possible. And use a variety of different strategies, some of which you may be familiar with, including sort of clinical high risk or at-risk mental state approach. There's some other work, including some work that we're doing in Toronto and in other areas, including through the ABCD study and the Philadelphia Neurodevelopmental Cohort study, for example, to look at psychosis spectrum symptoms with the notion that some of those people may actually never present for early intervention until it's too late, until after the onset of psychosis. But there's a lot of individuals in this sort of early phase in their teens and 20s who are presenting for other mental health conditions prior to presenting with the first episode of psychosis. And it looks like those individuals may be, quote unquote, hiding in plain sight, in part because we're not looking for it. When a young individual is coming in with depression and anxiety and emotion dysregulation or substance use. We're focused on those things that are much more prevalent, but missing the fact that a lot of those folks, and in our data across about 400 people, about 50% of those people are actually scoring above threshold for psychosis spectrum symptoms. And so the point there is to emphasize that this is an illness that starts early. We still have a lot of work to do to understand and identify those individuals as early as possible. And then through that, understand how we can alter those trajectories and improve some of our treatments. But nonetheless, we need to be mindful of that and recognize that this is a developing process for a lot of individuals. This is some old data from the ABC study, but still relevant today. Most people are presenting in their teens and 20s and into their mid-30s. And I'll show you some provincial data a bit later. And then that starts overall a downward trajectory in terms of recovery and functioning, although with a lot of variability in outcomes for people over time. And we've also seen that schizophrenia and psychotic disorders in general are one of the top causes of disability in youth, both in males and females. And early psychosis is linked to an increased risk for mortality. This is some data from Paul Kurdiak and his group looking at provincial health data in Ontario, indicating and showing if you follow people over 5 years, that individuals who are coming with their first diagnosis of schizophrenia spectrum disorder have a substantially elevated risk of mortality, of all-cause mortality. This is 1 in 25 people will die who are diagnosed in hospital, and 1 in 40 of the individuals that are diagnosed in a community setting. So that's 13 times and 9 times higher than the rate in the matched general population. We've also seen that there's an increased level, not just an increased risk, not only of all-cause mortality, but also suicide risk. This is some unpublished data by Paul Kurdiak from ICES, which is a data analysis team that leverages administrative health data in the province. So they followed just over 75,000 individuals with an index diagnosis of a schizophrenia spectrum disorder over the course of 10 years. 1.7% of that population died by suicide. So that's 17 times higher than the general population. And what's interesting to note here, even though I mentioned that ABC study was old data from about 23, 24 years ago, that we're still seeing that the age, at least in the administrative health data, the age at first diagnosis is about 30 years old. Now, I'd like you to think about that when we think about the usual population that we're seeing when it comes to early intervention for psychosis, which is typically much younger, and that the age at death by suicide on average was about 35 years old. So this raises some important questions for us when thinking about what that age range is and what we need to understand in terms of who we are making quote unquote eligible or we are accepting into our early intervention services, and also potentially how long we are following people for. We've also seen, this is some data by Kelly Anderson. This is looking at the London PEP program and that catchment area, but very similar to what other people have seen, that we are missing people from our early intervention program. So that data from that defined catchment area where the follow-up is a bit easier to identify who did and did not get epi services would suggest that about 50% of individuals who are being diagnosed with the first episode of psychosis never actually make it into an early intervention program. And so the volumes that we're seeing are a fraction of what's actually happening in the population. The odds of being referred were increased if you were male and if you were diagnosed in hospital, probably a no-brainer for most people. At least the kind of hospital piece, you would hope that at least in hospital, people would know where to be able to access early intervention services. But things that decreased the likelihood of referral included being from a socioeconomically deprived neighborhood, being diagnosed in an outpatient setting, having a previous diagnosis of an alcohol-related disorder, or a prior diagnosis of a substance-related disorder. Again, we've seen this clinically. I'm sure you've seen it as well. This notion that there are people who experience a first episode of psychosis, and then there are people who experience substance-induced psychosis, and somehow those are two separate populations. Although the data wouldn't actually support that, because there's a lot of transition and conversion over time from substance-induced psychosis into a diagnosable schizophrenia spectrum disorder. There's also been some interesting work looking at how people are accessing services. This is an example of some work by Max Birchwood that looked at the duration of untreated psychosis, and I'm happy later on to have a debate with anybody about DUP and all of that. It continues to be a debate in our field, but what's important is that the focus on DUP allows us to think about care pathways and the ways in which people are accessing care and the different types of delays that people can experience not just because of the structures that we have in place within our health system, but also based on who the referral is coming from. So here you'll see they looked at sort of all individuals in this population, about 340, but they also divided people based on a short DUP, which they suggested was less than 6 months, and a longer DUP, or duration of untreated psychosis, of greater than 6 months. And then, what's certainly very dramatic here is if you look at the median delays within each bucket. So anywhere from 0 to a few days, in most cases, up to a couple of months in the under 6 months of duration of untreated psychosis population versus, 66 days in help seeking. They do pretty good in terms of referral to mental health services, but then sort of lengthy delays again in, within the health system and being connected to an early intervention service. And there are also differential successes and delays when it comes to being referred by a different category or different group of service providers, whether it's community mental health teams or child and adolescent mental health services that have longer delays relative to, say, home treatment teams or psychiatric hospitals. And so the reason to bring this up is to really highlight the fact that we need to be thinking about the care pathways and the different sort of steps along that journey for individuals to recognize or present for concerns about something that's changed in their experience, and then how we as a system then help connect people to the right place. And if we understand that, then it allows us to do some interesting things, including thinking about how we can intervene as a system to help enable the success of people in getting connected with the service that they should be connected with. And so there's been some meta-analyses that have been done looking at interventions to reduce the duration of untreated psychosis. Frankly, there's not a lot of good data overall, but what it does suggest, if you look at some of the examples, is that this probably needs to be a bit more of a tailored approach. So we need to understand within our local system, and this for you, as for me as well in Ontario, will look very different. If in Ontario, for example, we're looking at delays in care pathways in Toronto or in London or in Ottawa or Kingston versus Thunder Bay or North Bay or Sudbury or other areas where individuals have to go to a nursing station that is inaccessible at some times of the year. And so the reason for delays may not be the same for everybody, but understanding those delays then allows us to do some interesting things, like thinking about, what you see on the left there, the opportunity to create and start up new early intervention services that can reduce the experienced duration of untreated psychosis for the local population, or utilizing media campaigns and helping bring awareness to people about the experience of psychosis so that they feel comfortable to reach out and speak to somebody. And over the years, we've seen some consistent data to suggest that early psychosis intervention works. It works to help keep people connected to treatment so that they're not dropping out of care. It reduces overall hospitalizations and relapse rates. It also improves recovery and functional outcomes for individuals. What's interesting is that in that same work that Kelly Anderson had done, it also looks like individuals who are connected with an early intervention program have a reduced risk of mortality relative to people who don't. So the mortality rate for individuals in an EPI program is on the green line at the bottom, and the mortality rate for individuals not connected to an EPI program, remember that 50% that I was telling you about earlier, is in the orange line up at the top. So a dramatic difference in the mortality risk for those two groups. So in addition to knowing that early psychosis intervention is effective, we also know that keeping people in services is incredibly challenging. And we struggle, like many other populations, we struggle with disengagement from clinical care from the population that we serve and that we want to provide services for. And this includes high rates of non-adherence to medications and non-attendance to treatment, and all-out premature termination of services. And that continues to be a big challenge for us. We've also seen over the years a number of efforts to develop standards and help guide the delivery of high quality care for schizophrenia spectrum disorders more broadly and other areas. These are some examples. So hopefully people are familiar with the Canadian practice guidelines that came out a few years ago that were updated. There's also in Ontario, a part of Ontario Health called Health Quality Ontario that has been developing quality standards for a number of areas, including schizophrenia, both for the care of this population in the community and for the care of this population in hospital. That's similar to the guidelines, provide some core components of what all services should be providing, and some guidance around how to measure it. And this would include things like family therapy for individuals, CBT for psychosis, identifying if someone has treatment-resistant schizophrenia, offering them clozapine, and for individuals who don't have treatment-resistant schizophrenia, making sure that we're at least having a conversation with them about long-acting injectable medications as an alternative to oral antipsychotics. We've also seen some similar work that's happened in the US through the APA, the NICE guidelines, of course, in the UK. And then when it comes to early psychosis intervention, we've also seen the development of some early psychosis intervention standards. I include BC here at the top in part because I'm gracious to be here and I like being in Vancouver, but also because the BC EPI standards actually came out before the Ontario one. So the BC EPI standards came out in 2010, and then Ontario published their EPI standards in 2011. There has been no changes since that time. We can argue whether or not our understanding of how to treat this population has changed fundamentally since then, and whether or not there is a need to change those standards or to update them. I'm not convinced that there is. But most teams have utilized these standards to help articulate what their model of care is. But they've typically done that in a bit of an ad hoc way, in part driven by funding, in part driven by the particular needs or perceived needs of the local population. And then through that, try to adhere as much as possible to some or all of the standards. But in an underserved or underfunded system, often we end up having to make very difficult decisions. And so what we've seen locally, for example, in Ontario, is that teams will typically choose to stay much more adherent to things like a caseload ratio, one of my pet peeves, I'll be frank, rather than ensuring early access. So, the notion that we can make people wait 6 months or longer to be able to access early intervention services so we don't go above a 1 in 20 or 1 in 25 caseload ratio is potentially a bit problematic. And so there have been guidelines. The implementation of those and those standards has been more challenging. And what's been exciting is that in the face of that, because we're not unique, many people experience these challenges, we've seen the emergence of coordinated specialty care to help shape and guide how we deliver early psychosis intervention. So coordinated specialty care, or CSC, is a recovery-oriented, team-based approach to delivering early psychosis that promotes early access, shared decision-making, so bringing the individual and their family to the table to make shared decisions and to personalize the care that they are receiving, and to coordinate a number of activities simultaneously around that individual and their family. And so this includes things like individual and group psychotherapy, family support and education, medication management and monitoring of side effects and physical health, supported employment and education services, and case management. And in some cases, peer support as well. And many people would say, when I ask other teams, they would say, oh, well, we do all of these things as well. And I would argue that early on in my career, when I was doing a lot of this early work in our former sort of case management style model, I would argue that we theoretically did those things as well. But the reality is that there were many, many, many people who came through our services, that we did a very good job of providing medication treatment and putting out fires. And we did not do as good of a job understanding their strengths, understanding their goals, and helping them work towards meaningful goals that are defined by the individual in front of us and by their family. And we would only have conversations with people about school and work at around the 2-year mark, 3-year mark, if we were able to reduce the intensity of their psychotic symptoms. Because we had this sort of historic notion that if we couldn't treat the psychotic symptoms, we couldn't have another conversation about anything else. And it put us in a bit of a difficult situation where we were potentially prejudging what our patients and their families were, quote unquote, capable of handling. And so what coordinated specialty care does is flip that around and says, doesn't matter, we need to offer this to everybody all of the time right from the outset. So everybody coming into services should have access to all of those things simultaneously, and then give people the option to say yes or no. And to know that we are offering those services so that we can then come back and connect with them again when they are ready to talk about it again. But at least they've been given that information. And so two of the sort of exemplars of this are things that emerged, models of care that emerged from the RAISE study, the Recovery After a First Schizophrenia Episode Early Treatment Program initiative from the National Institute of Mental Health, which was really focused on developing these coordinated specialty care programs. One of them is called Navigate, doesn't stand for anything. And the other is called On Track New York. I will speak about the first one, about Navigate, in part because that was the one where they did a cluster randomized controlled trial comparing the receipt of Navigate versus the receipt of treatment as usual across the United States. On Track followed a similar path, but did an implementation study that basically demonstrated that it's possible to not just do this in the context of a randomized clinical trial, but also to implement that in the real world. And then through that, what's now happened is the growth of coordinated specialty care services for early intervention across the US. These are organized within states. And then the National Institute of Mental Health has layered on top of that something called EpiNet, Epi Network, creatively. And through that helped establish common measures. So common assessments and common principles, both at the patient and the system level or the service level, for how to harmonize measurement across coordinated specialty care networks within each state. And to be able to bring that together to help us understand and advance our understanding of how we deliver services for this population and improve outcomes. And so I said that I would focus a little bit on Navigate, and you'll see why a little bit later. So this is a manualized approach to be able to deliver coordinated specialty care. So think of it as a playbook. Right? So this helps articulate not just what we should be doing, but the how of what we should be doing in a bit of a stepwise and modular way, sort of like a curriculum, both for us and for our patients. And this includes things like an individual resiliency training, which is a strengths, positive psychology informed, CBT informed approach that engages people and helps them define their goals and identify that despite all of the other things that are happening in their lives, they still have some strengths that they bring to the table. Supported employment and education, which is, as it sounds, building off of the individual placement and support model, but again, being offered early within the first month of coming into an early intervention program. Family education, so additional work specifically focused on family, again offered at the start of treatment. For the psychiatrists in the room, we've been relegated to quote unquote prescribers. That's okay, we won't take a personal offense to it, but there are other sort of system reasons for it. But the sort of prescriber role is really responsible for symptom measurement and using those measures to guide evidence-based decision-making, including managing things like side effects, and how we engage people in routinely checking in on the side effects, and using that to then help ensure that people are connected to their care and to their treatment team so that we don't, as we typically do now, find out sort of a year later that someone who we thought was taking a medication that we continue to prescribe a medication for and renew that medication and would check in with them and say, how are things? And they would say, great. We find out a year later that they haven't been taking that medication because they didn't feel comfortable to talk to us about the side effects that they were experiencing, including weight gain, sexual side effects, and just not feeling comfortable being on a medication because they're young people, and young people are not used to being on medication, nor are older people. A different story. And then finally, a director who coordinates all of this and makes sure that for every individual in their family, that there is someone who is coordinating the activities of this multi-person team around everybody that comes into those services. And so we saw in the literature, there was the data that came out from the RAISE trial for Navigate, indicating that Navigate or coordinated specialty care was superior to treatment as usual early intervention for psychosis, and in particular for individuals who had a duration of untreated psychosis of under 74 weeks, which was their median. So they did a median split and looked at differential rates of improvement in those groups relative to treatment as usual. So really highlighting the fact that if we can see people early and get them into care early and provide comprehensive coordinated care, we can surpass outcomes compared to regular treatment. And this also translates to higher receipt and engagement in services, including individual resiliency training, shown here in the first panel, and family education in the second panel, and then also an increased engagement in supported employment and engagement, which then is linked to better work and school outcomes for individuals. I did mention some of the struggles around disengagement, and I sort of highlight this here. This is some work that was done in our center. So at the Slate Center, which is our early psychosis services at CAMH, we implemented Navigate in late 2017, and that's been our model of care since that time. Through health records for individuals who have received care, we looked at predictors of disengagement from services. And what we found is an overall rate of disengagement of about 17.5%. The predictors that seem to reduce the likelihood of disengaging from care were early use of individual resiliency training and early engagement with supported employment and education with that worker, with the asterisk indicating what survived in a sort of multivariate model. And things that increased the likelihood of people disengaging were early medication non-adherence, legal involvement, homelessness, and identifying as Asian. And important for us to be mindful that we have a diverse population, and we need to understand across our diverse population how we are doing in terms of engagement for all of those individuals that are coming through. And in Ontario, we've seen that although there are standards, they're not necessarily enough on their own. This is some work looking at a fidelity evaluation to psychosis standards in Ontario that highlights part of what I've been describing up until now, which is that we do pretty good in terms of reducing relapse, prescribing medications, putting out fires, doing some of the case management stuff, the bars on the left. But what we really struggle with are things like substance use supports, education supports, employment supports. Family work is not shown there, but it is in the same sort of range in the 60 to 70% from a fidelity perspective. So really struggling in what I would argue are the at least, if not more important components from a psychosocial care and recovery perspective. Those are the things that teams have consistently struggled with for a variety of reasons. Resources, inconsistent approaches, you name it. And in Ontario, we have 52 EPI programs across the province. And you can imagine there is a ton of variability across all of those for a whole host of reasons, some geographic, some funding, but also a lack of a consistent approach for how these teams, newly developed or existing teams, will actually deliver early psychosis care in a consistent way that is the same if you're in Thunder Bay as it is in Toronto or in Niagara. And so we had this opportunity to apply for, and we're successful at getting a CHR grant to look at implementing Navigate across diverse settings. And the goal there was to look at implementation outcomes. And in particular, if you take an evidence-based model of care, can you implement it in a range of different settings? And does that lead to an improvement in fidelity to EPI standards? And then, of course, because we like to evaluate lots of things, we also wanted to understand system-level impacts using administrative health data, patient-level outcomes, as well as engagement of family and youth who we had included as partners in the design and delivery of this implementation trial. And so we started in the beginning of 2019. In addition to about 2,000 individuals at CAMH that have received Navigate, another 1,000 individuals since early 2019 have received Navigate-based early intervention in this trial across the province. We've trained, 1,000. We've trained over 100 clinicians as part of this, in addition to the folks that we've trained locally. And what we found is that within the psychosocial care domain of that fidelity assessment from Don Addington, the improvement that we found was in the things that we hypothesized. So improvement in teams' fidelity to supported employment, supported education, and family supports. And the CBT piece is a bit of a challenge Remember, this was also done during the pandemic, which nobody predicted, and the measurement of how you deliver CBT and whether it's formal CBT-P in a kind of structured, pure way versus CBT-informed care with cognitive restructuring, et cetera, in the context of individualized resiliency training, which is a component there, is not measured or valued in the same way, at least with a fidelity assessment. We've also seen improvements in functioning, both based on the quality of life, the same measure that was used in the RAISE trial, and importantly of the same magnitude, so a 15-point improvement on average for individuals that they saw in the RAISE trial, the same about 15-point improvement in what we've seen in Ontario, and also an improvement on the SOFA score. We also had an interesting opportunity to partner with ECHO, the Extension of Community Health Outcomes. This is a video-based community of practice that came out of the University of New Mexico that has been implemented since 2015 in Ontario. There's a number of these virtual communities of practice that are really about capacity building and helping improve outcomes for patients through capacity building of their care providers. We started the early psychosis ECHO in August of 2019. We are now at the end of our 4th cycle. From a curriculum perspective, we've been working with these teams. So we bring these teams together twice a month by video for an hour. Part of that is a case-based discussion that one of the teams will bring. And we use that as an opportunity for the teams to learn from each other how to implement coordinated specialty care using a real-life example that often mirrors what other people are struggling with, but an opportunity for the teams to learn from each other as well and to hear from other clinicians who have struggled with the same situations, but in a different environment, how they've managed to tackle it. And then we follow that with a bit of a didactic component to ensure that we are also using it as an opportunity for booster sessions. So things like, how to use a particular component within IRT or to do supported employment and education. We also include some sessions on measurement-based care and addictions or substance use. And we also bring patients and family members in to share and to be part of some of those discussions and those didactic presentations. And because this happened during the pandemic, we were forced to pivot quickly and figure out how we're going to deliver what is a paper-based manual. So I don't know if any of you have seen the Navigate manual. So this is the IRT component itself is about 970 pages. A small tome that's good for insomnia. So that is split between the clinician-facing manual and patient-facing handouts. But delivering that by Zoom or WebEx or Teams, you can imagine was incredibly cumbersome. And because it was important for us to try to understand and quickly get to still engaging with our patients while they were at home and everybody was terrified to leave their home and come into a hospital, we needed to work with our internal team to adapt some of those tools, and in particular, the things that the patients were completing, these sort of checklists around strengths and resilience and goals, to be able to send those by video and get people while working with us to still complete those things so we could still adhere to the structure of our model of care. And we then, this is some work by Nikki Kozlov, we then used a virtual client experience survey and a virtual provider experience survey that was happening at CAMH anyways to check in with our patients and families who found it resoundingly positive, this sort of delivery of care. And in fact, over 3/4 of those individuals felt that delivering Navigate virtually was just as effective as delivering it in person or receiving it in person. A bit less when it came to the clinicians. They were at about 62%, but still more than the majority thought that it was still an effective way to deliver early psychosis intervention. And we've built on some of that and have now developed e-learning modules to digitize the Navigate manuals, both for the clinician to support training and capacity building, and also for patients, and provide some sort of introductory work for new teams. And this is an example of what this looks like. So this is an e-learning type of approach. The clinician side is on the left, the patient side is on the right. So this is the same module. We stayed as true to the US-based Navigate model as possible. We Ontarianized it or Canadianized it a little bit, and we changed the font. It was Comic Sans. And so what you see here is that there's an opportunity both to see the content in a sort of compact way with some key messages, but then to be able to click on some of the links and download the fillable PDF. So as a patient, I can access this from my phone. I can fill out those links. I can do it while I'm on the video with my clinician, but I can also do it between appointments as well. And then for the clinicians, they have access to not only their content as a bit of a reminder around, what are the goals of this module. It also provides some tips and strategies, timing, how many sessions typically it takes, how to pace the session, but also provides links to the same measures and instruments that the patient will be seeing. So that if you're using this to prepare for an upcoming session, or you're in the midst of a session, you want to quickly remind yourself, you can bring this up and you can quickly see all of the things that you need to have access to without flipping through a 900-page manual. And of course, things are not always all roses, as we know. We know that early intervention actually leads to impressive outcomes over the short term. We continue to struggle over the long term. This is some data from Opus. I include it here, mostly because the 20-year results just came out relatively recently. On the left, what we see is the proportion of individuals who have recovered and who are in symptomatic remission. That gets to about 40-ish, 45% over time. But we still struggle with people who are still in symptomatic remission, and a smaller proportion, but still a sizable number, who are still hospitalized. And over 20 years, it looks like those early gains from early intervention are no longer present when people then just continue with treatment as usual, which I would argue is maybe not surprising. If I have diabetes and I stop physical exercise, eating healthy, and my insulin, then my outcomes are probably going to deteriorate, and my physical functioning is going to get worse, and I'll have a whole host of other complications. And so really what this highlights is that we need to start somewhere. So we need to start at early intervention, but we can't lose sight of the fact that many of these folks will need continued coordinated care at a high quality level that's grounded in evidence over the course of their lifetime. We just need to be able to better predict who those people are going to be and how to stage treatment for them. So that brings me to some of the work we've been doing with Ontario Health. So the Mental Health and Addiction Center of Excellence is focused on building a comprehensive and connected mental health and addictions system across the province of Ontario, and overseeing the delivery and the quality and access to high quality care for everybody, regardless of where they live. And the goals there are to implement some of the key priorities within the roadmap to wellness that was developed by the provincial government and the ministry. And this includes 4 pillars. So improving quality, expanding existing services, implementing innovative solutions, and improving access. And there are 4 clinical areas of focus: depression and anxiety related disorders, schizophrenia and psychosis that I lead, eating disorders and substance use disorders. And layered across all of those are some key kind of pillars and groups, including performance planning and or program planning and performance management, evidence-based services, monitoring and system performance, access and system navigation, stakeholder engagement, and a data and digital strategy, with health equity and Indigenous health layered throughout. And so hopefully I've made the case for you that early intervention is important, and there's a lot of variability and gaps that we need to address. And so we thought that this was an opportunity for the Mental Health and Addiction COE to start building a provincial program in early psychosis. For a number of reasons, we're able to identify this population in administrative health data. We have a provincial infrastructure, so we've had a network called Epion for a number of years that's been in existence that has been bringing these teams together. We have evidence-based treatment programs, and we have provincial standards to make sure that we're aligned and on track. But the gaps are that access continues to be a problem. There is inconsistent eligibility across the province. You may live on this side of the street and be eligible. You may live on that side of the street and not be eligible. Not just based on the postal code, but also based on the fact that this service on this side only accepts people if they've had less than 1 month of antipsychotic treatment, whereas that service doesn't care how long you've been treated with an antipsychotic for, even if it was just the family doctor who prescribed it. Right? So a huge challenge for our population. We don't know yet. It's sort of like the Starbucks model. Epi services kind of pop up all over the place. We don't know if the location of those services is where the population needs them. because we haven't used, up until now, we haven't used data to design and figure out what the demand is and where we need the supply. And we don't have a good mechanism provincially to monitor system level and patient level outcomes and use that for continuous quality improvement. And so our vision is to do all of those things. It's a small undertaking. So we want to have an evidence-based model of care, have consistent and harmonized eligibility criteria that are part of a coordinated and integrated pathway for our population that starts at early psychosis, but then continues for the people that need ongoing care. That access to this is coordinated provincially rather than locally, rather than each individual service saying, I'm going to manage the referrals on my own and never be accountable to anybody else about it. Having a provincial way of managing and coordinating access so that we can understand where we're succeeding and where we're struggling. And then also use evidence-based standards to then define and set expectations around what the services should actually be providing. And through that quality, yoking funding expectations to that. I mentioned the supply and demand piece, so using data to understand and drive capacity planning. To develop a hub and spoke model, we are large provinces, right? So not every solution is going to be the same, or the way it gets implemented is going to be exactly the same in one region versus another, because there are different and unique needs. And so a hub and spoke model offers us an approach to be able to have a bit more of a regionally specialized and tailored approach while still having a connected system. And then ensuring that the funding model is tied both to the model of care, so that we're actually funding teams based on what we're asking them and expecting them to deliver, and based on the expected demand that they should be dealing with. And then finally, performance management and accountability, because we need to be accountable to the taxpayers for the money that we're spending to deliver healthcare. And so that involves setting some key provincial indicators, setting clear expectations and accountability for the EPI teams, leveraging the data and digital strategy and the provincial data set that the Mental Health and Addiction COE is building to have consistent measurement across the province for all patients intersecting with the mental health and addiction sector, and then building and expanding on communities of practice so that we continue to bring people together and learn as a system over time. And so we assembled a task group to design this provincial EPI program. And we did a number of things. We conducted, of course, the literature search to evaluate the current state of the evidence. We looked both at the Cochrane reviews, which are arguably very stringent, but also other systematic reviews and meta-analyses that looked at different models of care. And essentially it came down to two models. One was a case management model, the usual thing that most people have been doing, which is case manager and psychiatrist plus sort of other clinicians that are available in a bit of an ad hoc way, and coordinated specialty care. We had an extensive discussion with that group, and then subsequently with the Schizophrenia and Psychosis Advisory Table that I chair, that the EPI task group reports to, and then through there to the clinical council at the Center of Excellence to review and propose and get endorsement for our direction. And then over the course of a series of meetings, a couple at the EPI task group, and then 2 or so at our advisory table, and then finally at our clinical council, the chosen model was coordinated specialty care, for hopefully obvious reasons. If I've done a good job with this talk, you will understand why. And in particular, the Navigate model, because we have some local experience with it, and there's also learnings, digital content, and already a curriculum for enabling capacity building. And so that's sort of what's articulated here on this slide. The other sort of important pieces here are that there, in addition to the existing infrastructure here, there are also some unique opportunities for us to be able to connect when we think about measurement and system level performance and building a learning health system, to connect with the kinds of things that are happening in the US through EpiNet, and also internationally in the context of coordinated specialty care. So an opportunity to think not just locally or provincially or nationally, but also internationally as we work towards improving outcomes for this population globally. And so I mentioned the components here. So Navigate aligns with the core components based on quality standards, based on the EPI standards, whether it's your EPI standards here in your province or mine in my province, those sort of 4 key buckets. And as I mentioned before, Navigate provides a bit of a playbook so that if you're walking into a service, you know what you're going to be delivering, and the patients and their families know what they should be receiving. And it's easy to articulate that, and it's consistent whether you're here or you're in Kelowna or Penticton or Revelstoke. That if you are accessing EPI services, it is exactly the same. Because what we've struggled with is that, and now made easier because of the pandemic and the shift to virtual care, we see people from 2, 3, 4 hours away by car because they can access services and they don't trust that their local service is actually going to be delivering and providing the same high quality care. But I would argue that that's suboptimal because we are just not as good in understanding the local environmental needs for that population. And so we need to shift things and provide the same high quality care in those populations. And so this is what that provincial model will look like. So the 4 components of Navigate that surround coordinated specialty care, as well as peer support that we have borrowed from and will be borrowing from On Track New York, to make sure that as part of our coordinated specialty care, we are also providing and engaging peer support in helping foster and improve outcomes for our patients and their families. And then being mindful that there are a number of other gaps that we need to be addressing, including physical health monitoring and engagement with primary care, cultural sensitivity and health equity for our diverse population, which is diverse across our provinces and also certainly across our countries. And so we still have some work to do. And then always keeping a mind open for the other things that we need to be thinking about and evolving over time, because this is a continuous process. And we have some administrative health data to be able to understand not only how many people across the province are presenting to our services, our EPI services, but also how many people are being diagnosed anywhere across our health system for the first time with a psychotic disorder, any psychotic disorder. And then based on that, we can understand by region what the demand is and what the incidence rate is, even though we recognize that for now, although we're going to work on that gap as well, only 50% of those people are actually presenting for EPI care. And we can drill down even further by looking not only at overall population incidence, but we can break it down by age, which we used to understand what our minimum age and maximum age from a harmonized eligibility perspective should be. And based on this data, you see sort of 14 to 20 and 21 to 25 at the top, probably not a surprise to most people, but a high incidence rates across the board. I challenge you to draw a horizontal line there and separate the group that should be in EPI versus those that shouldn't. The approach that we've taken is that these need to be developmentally informed services, and we need to draw a line somewhere, but be mindful and use the data to continuously evaluate whether or not we still have gaps and make sure that other people are also able to access services. And we've been able to do this. This is monthly incidence rates, but we've been able to have this data also for affective psychosis. This is not all affective psychosis. These are individuals who are being hospitalized with bipolar disorder, with the extrapolation that is likely connected to a higher likelihood of having a psychotic bipolar disorder. But again, some data in an imperfect world because of the way we report diagnoses to help us understand and make some data-informed decisions around what age range we should be focused on. And so based on this kind of data and a review of the trials that have been done and across jurisdictions, the provincial and national and international guidelines, what we have come to is some harmonized eligibility criteria that would focus on people from 14 to 35 years of age with a bit of flex on an as needed basis on the borders, both younger. It's a small percentage. We've looked at those 12 to 13-year-olds. It is very, very small, but they do exist, as some of you here may know, and have seen clinically. And then also the 35 to 40-year-old folks, that's a group that we really need to be mindful of. So we are starting here, but being mindful of some of the border kind of groups. From a diagnosis perspective, we are keeping it open. So schizophrenia spectrum disorder, affective psychosis, and substance-induced psychosis. Not excluding people because of developmental disabilities, but because treatments can be different. making sure that we are, if people are presenting with a medical condition that's causing psychosis, that they are being connected to other appropriate services. And then the other piece that we've taken a much broader approach than what a lot of our services individually have done is to not set restrictions around prior treatment. So if you have not received 3 years of epicare and you are within the first 5 years of a diagnosis, you're eligible. And if not, then you would go to a multi-episode service. So we're not going to be excluding people because, I joke that, in some regions, people will walk by a pharmacy that dispenses antipsychotics and that makes them ineligible. But, in all seriousness, if a family doctor were to start somebody on an antipsychotic medication and it took them 6 months to then agree to a referral to an epi program, some services would exclude that person from early intervention. So, and then finally, when thinking about program length, we stuck with what we did, what had been stated in the provincial EPI standards, which was really focusing on the first 3 years, which is pretty consistent with what other jurisdictions are doing, and recognizing that people may graduate early, so it's not 3 years or nothing. That some people may not need 3 years, and so they can graduate early from those programs, and some people may come and go and struggle with engagement, and we need to have some flexibility there to try to help support engagement for this population and then connect them to their next step in services, which we will then continue to build. And with that, we'll thank everybody for your attention.
Thank you very much. Brilliant presentation, lots of food for thought. We don't have much time for questions, but we can take 2 now, and then during lunch, Dr. Fushes will be available for personal interactions that may be even more fruitful than just the questions here. So 2 questions. Dr. Sam.
Hi, thanks so much, Dr. Fushes. That's a wonderful talk, and just love the integration of the large, big picture, down to the small level. There was that slide you had about the multiple domains of schizophrenia, and one element that I find very important, at least in clinical practice, one could have 2 very psychotic individuals, but my heart sinks when I see the name of one with very poor insight, and I know that I'm going to have to have hard discussions or difficult discussions with these individuals. When it comes to insight, which was one of your items there, is that seen as, in terms of research, is that a character trait? Like how would you identify that? Because some individuals can be very psychotic, very insightful, others not so much. And also when it comes to epi, is there a way to modify that element such that even 20 years down the road, if psychosocial functioning is still poor, not being able to work and such, would that trait be any better in terms of their trajectory?
It's an interesting question. So insight for some individuals can be dynamic, and so they in the moment can struggle a lot with understanding what it is they're experiencing and why it should be treated, which then has implications, of course, for engagement and adherence. But for some individuals, it is dynamic and not a sort of static thing. There are other people who continue to struggle with a lack of insight for long periods of time, including people, this is not just people who are still symptomatic, but even people who are asymptomatic and in remission, who still have a lot of difficulty recalling previous episodes, lengthy hospitalizations and admissions to hospital. There's some work trying to look at how we can modify and improve insight. I don't know that we have a lot of great options. And then we, when we need to, we also use other levers that are available to us through the Mental Health Act to be able to ensure that people stay connected at least to a minimum degree. And then through that, try to work on building a bit of a relationship with people and helping them through measurement, through check-ins, through self-reported questionnaires to feel like they're connected to us in some way and that we're actually taking their experiences seriously, even though they may sort of technically lack insight into what it is that they've experienced and why they're on treatment, but they can still be partners in care.
And our second question is from Dr. Villa Rodriguez, who has been waving at me for the last 5 minutes. I cannot ignore him. So you go for that.
Thanks so much. Amazing effort, George. It's impressive what you folks are accomplishing in terms of optimization of care delivery and to really increase and improve the outcomes. I'm wondering if you could speak a little bit more about what are you embedding in this implementation effort in terms of a learning health system? What you spoke a little bit about the digital initiative and how to monitor outcomes, but where are you folks putting the emphasis and how do you intend to make and articulate that learning health system? And related to that, how is the system going to be is thinking about implementing potential new treatments, because you've spoken about how to really make the most of what we already have, which is critical. But we hope that we will bring in new novel treatments that will address some unmet needs. Thanks.
Thank you. So two very, very important questions. So the work through the provincial data set and the data and digital initiative is still ongoing. But we have seen, and I'm sure you're doing some similar work here, that there are these sort of harmonized sets of measures that are valuable and important within local health environments to deliver high quality care and to measure the success of that, and also to guide treatment, because we're not so good at picking up when things are changing clinically. So that's some of the work that's happened so far that is informing the approach. Provincially, there are some key indicators that we will need to have, primarily at a patient level focused on outcomes with things like the HUDAS, the Disability Assessment Schedule, because that really is, and recovery, because those are the things that we're really focused on, recognizing that the path to that can sometimes be symptoms, but sometimes not. And then also understanding other things like access to care, mortality, suicide. Those are the kinds of things that we see as shaping the learning health system. And some of that work is happening. We've been working feverishly at building this program, and there are other people in the Center of Excellence who are developing and working on how to deploy across a province and across different electronic health record systems, how to deploy measurement and bring that all together, which is an interesting challenge. And then the other part is that within our structures, we also have the ability to then bring through these task groups and that task group structure to bring for consideration over time as the evidence continues to improve, consideration for new treatment interventions. And that's the mechanism that's built into the structure of the COE for that.
Thank you. I apologize to people that are attending remotely. I know that there are questions in Slido. We don't have the time for this, but Dr. Fusius will try and address them during lunch directly on Slido. That's the best way of doing it. So I would like to thank you very much for being with us and sharing all your insights, and invite Dr. Murphy to moderate the lightning talk.
Okay, these lightning talks are always a lot of fun. Oh, okay. Okay. Okay.
Okay. Left turn.
Okay. All right. I guess I'd first thank Claire for hosting the first group, and we've got the second group of lightning talks, and
I don't know. I always find this a lot of fun that they go by quick, 4 minutes. And keep in mind, the questions are going to be at the end. We'll bring everybody forward and then have a general question and answer session. And also remember to vote on Slido. And I'm told you can submit all your votes at the end if you want, or if you want to vote for some that you've already decided on, you can do that. But of course, you can't vote for the same thing twice. It won't be counted. Okay, so the first talk is Leanne Cho, and she's a MD PhD student working in the Honer Lab, and she's looking at longitudinal associations between depression and suicidal ideation and psychotherapy and a lot of various mental health indices in a precariously housed sample, I guess the hotel project. Thank you.
Great. Good morning, everyone. So yes, my project is titled Longitudinal Associations of Depressive Symptom Severity, Suicidal Ideation, Psychopathology, Trauma, and Substance Use in a Precariously Housed Sample. In this study, my goal was to identify the risk factors of depressive symptom severity and suicidal ideation over monthly visits across 1 year. And our sample included in this analysis was a total of 393 participants that were recruited from Vancouver's downtown East Side neighborhood. The age median was 42 with an interquartile range of 33 to 50. The gender divide was about 78% men and 22% women. Ethnicity-wise, 61% white, 27% indigenous, and 12% identified as other. The minority of participants completed high school or their equivalent, and the majority, about 73%, experienced past homelessness. And then down here, is a depiction of my analysis structure. So in purple here is the lifetime assessments that were collected at the baseline assessment, everything up until the study entry. And then each of these circles here represent the monthly follow-up, so 12 in total over 1 year. And then at each month, we inquired about their depressive symptoms using the Beck Depression Inventory, the BDI, as well as about their suicidal ideation, and the recall period was the past week. The explanatory variables that we tested included the psychopathology symptoms, namely psychosis and anxiety, their substance use in the past week, and we also asked whether or not they experienced a traumatic event in the past month. So these are the risk factors that we identified for depressive symptom severity, namely lifetime major depressive disorder, current psychosis symptoms, and current anxiety were significant symptoms, or risk factors rather. So on this left panel here, no lifetime MDD, and on this panel here, with lifetime MDD. And you can see that those with higher comorbidity of psychopathology symptoms slipped into this range here above the red dotted line, which is the threshold to moderate to severe levels of depressive symptom severity. And the blue dotted line is the threshold between minimal and mild. Other risk factors we found were lifetime and recent trauma, as well as recent opioid use, which is depicted in these two panels below. So low lifetime trauma on the left and high lifetime trauma on the right. And you can see that everyone that had a high lifetime trauma, their depressive symptoms were already in the mild range, and those with lifetime major depression or higher frequency of non-prescribed opioid use had higher symptoms. And then these are the risk factors that we identified for suicidal ideation. This analysis was done in a subsample that had at least one BDI score of 19 or greater during the year, which we found previously to be likely indicative of a major depressive episode. And the significant risk factors we found were lifetime psychotic disorder, lifetime trauma, a current BDI score of 19 or greater, or higher anxiety symptoms. So these two panels here represent the psychotic disorder as the panels, anxiety symptoms on the x-axis, and the colors are the BDI score. And you can see that with higher psychopathology, the probability of suicidal ideation increases. Down here is the same information, but depicted with depressive symptom severity on the x-axis instead. So you can see that beyond a BDI score of 19, or this red dotted line, suicidal ideation risk increases quite steeply. And of course, with increased anxiety symptoms, that's even more so. So in summary, first, multiple psychiatric and social factors increase the risk for depressive symptom severity, and these may be targets for intervention in the community. And then second, among those who are experiencing moderate to severe levels of suicidal ideation, assessing past psychosis, past trauma, and current anxiety symptoms might be helpful for identifying suicidal ideation in the sample. Thank you.
Thank you, Leanne. Our next speaker is going to be Dr. Katrina Hittman, who is a postdoctoral fellow at the Women's Hospital, and she is supervised by Deirdre Ryan. And we'll be talking about postpartum psychiatric hospital admissions, a population-based study. Thank you.
Thank you very much. So I'm really grateful to have this opportunity to share with you some of my fellowship research with the BC Reproductive Mental Health Program at BC Women's Hospital. I'm going to start with grounding us in some of the clinical context. If a birthing individual in Canada requires hospitalization for postpartum mental illness, they will be separated from their infant for the hospitalization. And we know that that is traumatic for the whole family. There's also, we know that the perinatal period and this time in the postpartum is a time of particular vulnerability for mental health. We know from the literature, there are a couple studies showing the rates of hospitalizations in Denmark of 1 in 1,000 births, and in Australia at 8 in 1,000 births. But we don't know as much in Canada in terms of the current landscape. So that led me to my research question that was broken down specifically into sub-questions. What is the rate of hospitalization for postpartum mental illness? What are the characteristics of these hospitalizations? And what are the predictors? I did a retrospective population-based study that linked the BC Perinatal Data Registry data for all deliveries between 2015 and 2019 with other BC Health Services use data, including all hospital admissions, and then did use descriptive statistics and logistic regression modeling to address the research questions. For the rate of hospitalization that we found in this 5-year period was 4.3 in 1,000 births. In terms of who is it and what for, about 70% of those who were hospitalized had a previous history of psychiatric illness in the 2 years before conception or during the pregnancy, while 30% did not. Oh, sorry. And then they also, the most common reasons for admission were depression and substance-related disorders. In general, the length of the hospital stay was 3 days and occurred at around 5 months postpartum. The median timing of admission for psychosis was the one that happened closest in time to the delivery, but it was still later than we were expecting at about 3.5 months postpartum. For the predictors, I'd encourage everyone to check out my poster for the odds ratios and confidence intervals and some more of that detail. But the strongest predictors of hospitalization for postpartum mental illness were younger age and indices of previous psychiatric history. Still significant, but less strong were multiparity, short first stage of labor, low newborn APGAR score, and having a preterm baby admitted to the NICU. Which you can see kind of clustered together. And just to highlight a couple of points for discussion, the rate of hospitalization is broadly consistent with the previous literature, right between those previous rates. And the 30% of admissions for those with no documented history of psychiatric illness highlights the importance of screening for mental illness, as well as prenatal education and raising awareness of how to identify symptoms and then what to do for the patients as well as their support people. And finally, that the timing of the hospital admission being later than expected for psychosis in particular was interesting. And we wonder, there's a few possible explanations. Are the symptoms still occurring earlier, as we would expect in the first 1 or 2 weeks post-delivery, and they're just not being recognized? Or is there a health services access issue in terms of people getting turned away from the emergency room rather than being admitted? And then also we're wondering, maybe there's two kind of clusters in clinical profiles, like maybe people who have psychosis as more of a bipolar disorder diathesis, is maybe they're happening in the first couple of weeks, but then maybe there's psychosis as part of a picture of depression that's happening maybe later on, leading to this median rate. And I'd love to hear any thoughts or questions, and I can be reached by email or on Twitter. Thanks.
Okay, thank you, Katrina. Our next speaker is Dr. Quentin Clark, who is a PGY2 resident, and he is working with Dr. Daniel Vigo on stimulant use on campus. Thank you.
All right. Can everybody in the back hear me okay? Perfect, thanks. So good morning, everyone, and thank you for being here. Today, as mentioned, I'll be speaking about stimulant use disorder on campus, really looking at the characteristics and demographics of individuals using stimulants and meeting that DSM threshold for stimulant use disorder. And so in particular, the university campus that I'll be looking at is the one that we are at today, so the University of British Columbia. As we know from previous population level studies in the US, the general population incidence of stimulant use disorder is approximately 0.2%. Obviously, we know from past research as well that stimulant use on campus, that is stimulant use, not stimulant use disorder, is very prevalent and is noted to be associated with many factors, including first-time attendance at university, being the first family member to attend university, being of lower SES, or being a member of a Greek social society. The data for our project that I'll be speaking to today was collected as part of the Minder Student E-Mental Health project that was done in collaboration that was done as part of the Mental Health Systems and Services Laboratory. The data for this project was collected from a weekly cross-sectional study of students, survey of students between February 2020 and October 2022. Note that this study did continue past that point, but the data that I'm presenting on today is only for that period. This survey was based on the World Mental Health International College Student Survey that is used broadly for surveying college students across around the world. So in total, just over 11,000 participants responded to our survey. We had just under 2% of our student respondents meeting criteria for stimulant use disorder. The median age of these respondents was about 25, with an interquartile range of 8. With the majority of respondents being cis men, that's about 40%. 54% being cis women, and the remaining group identifying most prominently as non-binary. 65% of respondents were Caucasian, And the second largest racial ethnic group was South Asian students. Interestingly, in our findings, and somewhat troublingly, quite frankly, is that the majority of students who responded to our survey actually met criteria for severe stimulant use disorder. That was just over 70% of our respondents. This was certainly not anticipated by our team, as obviously being on campus and presumably being relatively high-functioning individuals, we would have assumed more mild to moderate severity stimulant use disorder in this population. Similarly, the types of stimulants that were being used by these individuals tended to be both a combination of prescription and street stimulants. That's 45% of our respondents endorsing use of both those types of stimulants. And this differs relatively somewhat from previous literature that has suggested more use of prescription stimulants in a non-prescribed manner in this population. So as such, among our university population, stimulant use disorder was predominantly of severe level of severity and included both street and prescription stimulants. The rate of stimulant use disorder in our population was just about 10 times the population level estimate in the US studies. And unfortunately, there are few comparable studies of stimulant use disorder among US or other international student populations. And so this is somewhat relatively new area, as much of the previous literature has really focused on stimulant use, but not so much that disorder level. So thank you for listening to my talk today, and I'm more than happy to take some questions later on.
Thank you again, Quentin. Some really startling statistics. I think that should stimulate some discussion. Okay, so our next speaker is going to be visiting assistant professor, Dr. Raja Kumari Reddy, and they will speak about putative cognitive decliners versus non-decliners in first episode mania, and they're working with both the Yatham lab and the Torres lab.
Thank you. Good afternoon, everybody. So today's topic is going to be on putative cognitive decliners versus non-decliners in first episode mania. I would like to start my presentation by thanking all the people involved. I'm here because of Dr. Yatham. Thank you, sir. And Dr. Ivan has supervised this entire study with professors from the iconic BD team, Professor Tamsin and Professor Elsia, with funding, and relentlessly who's been working for the last 20 years at the UBC Mood Disorder Center team. So as we all know, the bipolar disorder is characterized by both mania as well as depression, and cognitive deficit is the core feature, which is both which shares both endophenotype as well as it's compounded by various factors, specifically the medical comorbidities as well as substance disorders. The question is whether does it remain stable or does it decline over the period of time, as cognitive dysfunction is likely to have impact on poor functional outcome as well as a clinical outcome for the persons with bipolar disorder. The objective of this study henceforth is to look at the identify the cognitive decliners versus non-decliners, and also to estimate the percentage of the first episode patients who will show cognitive decline versus non-decline. And this was done with the sample of 88 persons with first episode mania. The main variables were cognitive ability as well as cognitive discrepancy. The analysis carried out was correlational matrix with binary regression, and we also looked at the outliers. Finally, logistic regression partial correlation was carried out. The dependent variable was the cognitive discrepancy score, which was obtained from cognitive general abilities and estimated premorbid IQ using NAT. There were 3 levels. One was the age. Second covariate was the symptom severity, race, and sex. Third variable, the primary predictors were number of previous episodes, psychosis, history of psychosis, and whether or not they were on lithium. As you can see the chart, there's not much of a difference. So to cut the long story short, this is the conclusion of the study, that there were about 32% of the first episode patients showed cognitive decline from their premorbid level. And there was no consistent clinical predictors to define the clinical decliners versus non-decliners. And they were defined by the, sorry, I just missed the definition. The decliners were defined as the dichotomous variables, that is minus 0.5, lesser than that and greater than that. So we did not get any consistent clinical predictors, hence periodic and longitudinal assessment would aid. The question is, should we go with the fact that it's just 32% of the entire population of the 88 persons that they had? So should we be happy to say it's just 32, so let's be happy? Or should we worry about the remaining 70% who has been maintaining well? So we would like to look at from a point of the spiral steps. It's a step towards understanding and preventing cognitive decline. In which direction? So are we spiraling down with the assessment, or should we go up? So it seems an uphill task with the early intervention and with the high risk group, which the team is already working on. I think Dr. Cam is working on in that. It would be a step for us to move forward and to look up in the direction for hopeful optimism of preventing this. That would be the way forward. Thank you all for your patient listening. Thank you.
Okay, thank you, Dr. Reddy. Our next speaker is Dr. Rebecca Zivanovic. And Rebecca is a PGY5 resident, soon to be graduating, and is doing research with Marianne Vidler in UBC OBGYN. And the topic is going to be the sort of attitudes and preferences of women with schizophrenia and bipolar disorder, as well as their care providers towards contraception.
Great, thank you. It's so exciting to have this opportunity to talk to all of you about this topic, and especially that we have 2 repro health related talks in this lightning talk is super exciting for me. In this brief presentation, I just want to mention that I do use the term women to generally refer to people who have the biological capacity to become pregnant, noting that not everybody within that category will identify as a woman. I also like to acknowledge that psychiatry has a long and dark history of taking a very paternalistic approach to the reproductive health, especially family planning of our clients. And it's really important to keep that in our minds as we talk about this work. So fertility rates in women with serious mental illness, which generally speaking includes schizophrenia spectrum disorders, bipolar disorders, and severe major depressive disorders, has steadily increased since deinstitutionalization, reaching in the last 10 or 20 years fertility rates that are equal to that of the general population. What differs is that women with serious mental illness within their pregnancies have much higher rates of unintended pregnancy. So in this top right-hand corner is data that we put together from our first systematic literature review. And you can see in the orange that 75% or upwards of pregnancies for people with schizophrenia spectrum disorders are unplanned or unintended. That's similarly high in bipolar disorder, consistently greater than control populations when they're looked at together, and in the blue, high rates of unintended pregnancy when these diagnoses are clustered together. An unintended pregnancy puts women at risk of many things. There are also parenting and perinatal related outcomes. So despite this, women are very unlikely to receive any contraceptive counseling from their mental health care providers. 1 to 30% of women within outpatient populations have received any contraceptive counseling ever. And that usually happens. The clinicians in the room will know when we're talking about teratogenic medications, and generally the tone of that conversation is you should not get pregnant, which is stigmatizing and judgmental. Then the bottom right, it just shows this is not a new problem. We have been talking about this for a long time. These studies consistently show this is something we need to do better at. I also like to note that women with schizophrenia are at particularly high risk of unintended pregnancy and then rapid repeat pregnancy after that. So being pregnant again within 12 months. So this systematic literature review, we started to try and look for attitudes, preferences, unique barriers that are perhaps having this problem endure in this unique population within clients as well as their mental health care providers. We found 16 studies to include in these results. 12 were studies of patient samples, which were all receiving care in an outpatient mental health clinic. 4 of these studies were of care providers. 8 of the studies were in North America, and they spanned 8 countries overall. So we looked internationally for ideas. So what we found was that 6 of these studies explicitly explored whether women would be open and interested in having contraceptive counseling, prescribing, and provision integrated within their mental health care. In all of the studies, the vast majority or all of the participants said that they would like this to happen. Some noting that this would actually be preferred because the providers also understand their psychiatric conditions and their mental health needs, as well as their psychotropic medications. There was also a suggestion, which I've alluded to, that routine discussion of pregnancy intention, rather than traditional contraceptive counseling or the way that we're doing this now, may be more acceptable because we need to have a shift in the stigmatizing and judgmental experience that many women have when they're receiving these kind of discussions with their mental health care providers. The studies of the mental health care providers found that the providers do consistently feel that they have a role in addressing reproductive health with their clients, but they recognize that they're not adequately fulfilling this role. Barriers that were identified to doing a better job with this were issues around stigma, lack of education and knowledge around what are the options for contraception, what should be included in contraceptive counseling. There's concern about working out of scope and discomfort with what clients want, whether clients would want them to be talking about this or not, which the studies thus far show that they do, as well as time pressure. We're all working within a really stressed system. And there's the thought that if we start talking about this, well, then will it take away time from the things that we do as mental health clinicians or psychiatrists? Barriers to contraception utilization in the client samples include things that are common systemic and socio-demographic barriers to contraception use in general populations all across Canada, things to do with funding, which we now don't have a problem with in BC because all contraception can be covered, including long-acting reversible contraceptives, but things like finding a provider, having the time, someone to put in your long-acting injectable, all of those things, lower education, lower income. But then there are also some illness-specific barriers that need to be considered. So in studies with schizophrenia, they're showing that there may be contributions of ambivalence, poor insight, and executive dysfunction that are all within the illness, as well as impulsivity and mania. And there is concern of both clients and providers about the impact that prescription contraception can have on psychiatric symptomatology and whether there are going to be interactions with the medications. So I think that that's a really exciting knowledge gap that can potentially be filled for both clients and providers. So in conclusion, there's work to be done to find acceptable and effective ways to integrate contraceptive counseling and provision into existing mental health care systems, such as potentially within early psychosis intervention programs as one idea. Thank you so much.
Okay, thank you, Rebecca. Our last lightning talk is Dr. Alexander Levitt, who is also a resident in the research track and is working with Fidel, Vila Rodriguez, and Cam Kermasian, and is going to be talking about Parkinson's disease and neuroimaging correlates and related to psychiatric illness.
All right, just set up a little bit better for the mic here. Thank you all for the opportunity to speak to some of my work on network analyses of neuropsychiatric symptoms of Parkinson's disease. I was hoping to first speak to why we should even care about psychiatric symptoms, in particular in Parkinson's disease. Well, whether it be depression, anxiety, or psychosis, there's consistent data to indicate that these are all under-recognized, under-treated, and associated with increased morbidity in Parkinson's disease. But moreover, I think that Parkinson's disease presents a very interesting opportunity as a model illness for a state of neurotransmitter deficiency. So we're all quite familiar with how there are loss of dopamine releasing neurons in Parkinson's disease, but one of the things that's not widely recognized is that there's also about a 50% loss of serotonin releasing neurons in Parkinson's disease as well. And we see that there are similar disruptions of noradrenergic systems as well. And these happen to be the neurotransmitter systems that we're modulating regularly in many of our first-line treatments. So I think there's a lot to be learned from Parkinson's disease. So we started looking into data from the Parkinson's Progression Markers Initiative. And this is a large database gathering data from 52 sites around the world. And now has data from hundreds of patients with Parkinson's disease that had just been diagnosed and then are followed through for about 5 years. Now there's also data starting to go out as far as 10 years. There's also data from individuals identified as being high risk for Parkinson's disease, or the prodromal cohort, as well as age-matched healthy controls. What we quickly found is that there's a very complex interplay between the motor and non-motor symptoms in Parkinson's disease. And we felt that the traditional statistical analyses weren't going to cut it and wanted to apply some of the newest means coming out from the field of network psychometrics. In particular, we were hoping to apply analyses that utilize pairwise random Markov field analyses, which has a lot of beautiful math to it, but today we're just going to focus on the graphical representation that these kinds of analyses present. So to start off, you can pick out your variables of interest, and then it helps to categorize them according to domain. So for example, you can group all your psychiatric symptoms and color code them, your motor symptoms in blue. And then each of these symptoms or disease parameters can be represented by these nodes. And then the relationship between any two nodes is captured by these edges. And the thickness of an edge corresponds with the strength of a relationship between any two nodes. So for example, we see that age and gray matter volume have a very strong relationship, whereas education and depression, not so much. And with this particular network analysis, any nodes that don't have a significant relationship, those edges fall off. And so there's a lot that we can do with this kind of graph and analysis. So we can start to look for clusters or communities of symptoms, or if you're particularly interested in just one symptom area, say, for example, you want to focus in on part 1 of the Universal Parkinson's Disease Rating Scale, which categorizes non-motor symptoms. Most of these are psychiatric. About 80% of the questions relate to psychiatric symptoms. And so you can see what are some of the factors that are most relevant to that particular symptom set. Or you can look at the network as a whole and try to identify what are the most influential nodes altogether. So we can see that gray matter volume is emerging as one of the most influential nodes in this network, which is quite surprising because I think oftentimes in Parkinson's disease research there's been a lot of emphasis on PET scans and dopamine deficiency. And then we see also that the part 2 of the Universal Parkinson's Disease Rating Scale is highly influential, as is the non-motor symptom set. And then we can use this quantification to see what happens over time. So from this database, as I mentioned, there is a cohort identified as being high risk. So these are the prodromal cohort. We can see that the part 3 of the Parkinson's Disease Rating Scale is influential, especially with the progression of the disease. And this has historically been the emphasis of a lot of neurological research of Parkinson's disease, because this is kind of the objective motor exam part of the assessment. But to our interest, across all stages of illness, we see that non-motor symptoms, which are predominantly psychiatric in this particular scale, the part 1 of the Universal Parkinson's Disease Rating Scale, are influential all throughout. Some other interesting trends that emerge, we see that depression becomes a highly influential node right around the time of Parkinson's disease diagnosis. And cognitive impairment seems to have a progressively more influential influence in the whole network of this disease syndrome as the illness progresses. So to summarize, network analyses provide crucial insights into the influence of psychiatric symptoms in Parkinson's disease, and the relative influence of specific symptom clusters changes over the course of the illness. With future work, we'll start to see whether particular nodes offer any prognostic information going forward as well. Thank you so much.
Okay, I'd like to now invite all the lightning talk speakers to come down for discussion and questions. So Alexander, come on back. And there's also the opportunity to put questions on Slido for those listening in remotely. And if you want, you can also do the voting on Slido. You can do it now, or you can do it after the question period. And let's see, I think there was a question on Slido already, and I think I'll just go right to that one. That's for Rebecca, and it was a question from Raj online, and was asking about, I guess, the kind of precarious position psychiatrists are in with people that don't necessarily have a primary care provider, and then kind of giving advice out of scope.
Yeah, and so I think this is something that I've been thinking about a lot over the last year or two, is how much do we want to be getting into this as psychiatrists? And that is a position that we are often in, especially when you're doing high acuity community work, is seeing people who may not have a connection to primary care. And it is the way that this is going to be advocating for psychiatrists to be doing this themselves. I don't think so, because I think that really what we need to be able to do is provide good contraceptive counseling. I do think that it is within our scope to understand what the options are, what are the side effect profiles, what are the benefits and risks, and how they interact with our medications. If you want to learn about that, I'm giving a workshop at the Pacific Psychopharmacology Conference about this with a contraceptive expert from OB-GYN here at UBC. But I think that knowing enough to be able to do good contraceptive counseling, and then knowing where you can send someone to have these, have things actually done. So there are specific sexual health clinics, women's health clinics, and things like that. So knowing what that is in your community, I think that that's probably where our responsibility is. Just saying you need to talk to someone about contraception isn't good enough. We need to have the discussion and be able to point people to a place where they can have good access.
Okay, do you have your microphone on in the back?
Maybe, oh, there we go. Hey, Rebecca, it's Raj. That was my question. I just got really excited and wanted to put it in there, forgetting that I was in person as well. My background's in family medicine, so your topic was actually really resonating with me, because that's a challenging situation. And with doing additional psych training, trying to strike that balance is difficult. And one thing that's also common that you mentioned was our patients who are potentially the most sick, potentially in most need of help, don't have those basic connections with medical care, either for lack of community resource or because even just getting to their mental health appointments is challenging enough. So I just wanted to commend you for bringing this to light, because it is such an important topic.
Yeah, thank you. And I think that we do need to recognize that there are clearly unique barriers and a reason why this is such a common problem that we have not been able to solve. And so I do think that there's a role for psychiatry to work within the collaborative system to be like, these are the things we know about these illnesses, how insight works, how family engagement works, how we can collaborate and try and like build up capacity with our primary care and OB colleagues to try and solve this problem.
There we go. My question's also for you. Do you look at different forms of contraception and how they interact with different psychiatric illnesses, or just the pill?
Definitely different forms. So I think that the oral contraceptive pill is definitely very low on what we are interested in. Generally speaking, when you look at the general population and some unique populations such as people with seizure disorders or epilepsy, the long-acting reversible contraceptives, when adequate education and counseling is provided, is generally what women who do not want to become pregnant would choose for themselves. So when counseling is provided, there is a provider, it is covered. More women than are currently receiving it would choose an IUD, an implant, or Depo-Provera also in some studies is quite popular with people with schizophrenia. There's some hypotheses that, people are already used to being treated with a long-acting injectable antipsychotic. So perhaps Depo-Provera will end up being more preferred. The next study that we are trying to do is to look at within our local population, what are the preferred contraceptive methods, but the pill is just so difficult for medication adherence, and it does have the highest risk of interaction with particularly affective symptoms, generally to do with mood because of the oral progesterone. So the long-acting reversible contraceptives certainly have less risk of medication interaction as well as psychiatric side effects.
Okay, lots of discussion on this topic. Questions for other speakers? Sophia.
Thank you. I have a question for two little ones for Dr. Clark, yes. The first one is a very sort of straightforward question. How did you do the probabilistic sampling? What were in your sample?
Right. So the students were signed up for the survey, and then weekly a sample was selected that would be chosen to complete the survey.
Just randomly?
Yeah.
Is that what you mean? Okay. And the second one, which is a little bit more provocative. Okay, people are taking drugs, so what?
Right. Fair enough. So I suppose I might agree with you in terms of stimulant use generally, but when we're at the threshold where someone is meeting criteria for stimulant use disorder, this is obviously having a substantial impact on their life in order just to meet the criterion for stimulant use disorder. And I should clarify that in terms of the severity specifiers that were used, these were DSM specifiers. So if individuals are saying having difficulty fulfilling their occupational or social roles, or not able or continuing to use despite negative health outcomes, or having tolerance or withdrawal symptoms, I think that is something that we as physicians and as healthcare providers should be concerned about. Particularly in a population that is relatively young and in a state right now where we're in a fentanyl poisoning crisis that has really contaminated the illicit drug supply, which apparently, based on the results that we have from the survey, is what our students are mostly using. And so I think it does behoove us to be quite concerned about the students who are using these substances.
Thank you.
Okay, any question? Maybe push it again so that it goes solid.
Hello,
Yeah.
there you go. My question is also for you about the stimulant use. So my first question was whether you could just quickly define the age group that was studied. And secondly, 70% is a really jarring statistic. I was wondering if you had more granularity in what types of stimulants are being used, just because I'm wondering, if this is an undergraduate population with the uptick in vaping, for example, being advertised to young people. I'm wondering if this is almost like a modern, I wouldn't say epidemic, but kind of phenomenon of why stimulant use is so high in this age group.
Sure. So just to clarify, it was a 2% prevalence in the study. The 70% figure was related to those who had a severe stimulant use disorder of those using stimulants. In terms of the substances being used, in terms of the age range, the median age was 25 with an IQR of 8. But in terms of like life stage aspects of what these students were enrolled in terms of programs at UBC, about 50% of them were undergraduate students, whereas another 30% were graduate students, with a 20% group which was non-degree students. Admittedly, I haven't explored that group much yet, but it is a bit of a curious question, as to my understanding, at least of UBC, the non-degree programs are not the vast majority of the programs that are offered here, and further, only about 15% of students at UBC are graduate students. So it would seem that the master's and PhD students are overrepresented in this group of stimulant users.
That checks out. Yeah.
Always good to know we're not in left field on this.
Right. And sorry, just to reiterate my second question about the actual specificity of the type of stimulants that are used.
Right. So the questions were relatively broadly asked. So the question was worded as, within the last, I believe it's 12 months, have you used street stimulants? And then examples were given of cocaine, or e.g. cocaine, but also would include certainly crystal methamphetamine or crack cocaine, versus people using prescription stimulants in a non-prescribed manner. So that would include things like Adderall, Ritalin, Vyvanse, modafinil, rarely. From the American studies, we know that people don't use modafinil that often. It tends to be more Ritalin and Adderall.
Yeah, for sure. Thank you so much.
Hi, I actually had a question for Dr. Clark as well. I just noticed that part of the data set was taken partly during when classes were all online and partly when they were all in person, so therefore in closer proximity to other students. So just wondering if you notice any differences between those two timelines.
It's a good question. Not one that we've explored yet, admittedly, but certainly something worth exploring. It is kind of by happenstance that when this data started to be collecting, the COVID pandemic started right at the beginning of it. So I think it probably does have a bit of an influence on probably not only how students were using stimulants, but also where they were sourcing the stimulants from. If they're not, say, on campus in person living in residence, but maybe are more likely to get them from relatives at home. Again, difficult to say, but certainly worth exploring.
I have a question for Alexander. I think in your network analysis, you talked about how we can find networks, but did you find any, or like the kind of like a pattern of different variables that in harmony would change through time as the disease progresses?
Sorry, what do you mean by in harmony?
So like the network would stay the same, or like a part of it would stay the same in terms of the relative node strength?
Rather we see that specific nodes emerge as being more influential on the network as a whole at different disease stages. So for example, depression in particular seems to be especially a large influential node at the time that shortly after Parkinson's disease is diagnosed. And there are certain things that become more influential on the rest of the network at different stages.
Okay, I see.
Yeah. Thank you.
Hi. I also have a question for Alexander.
I was wondering if you had explored the pathophysiology and the reasons why this psychiatric symptoms happen in Parkinson. Is it related to the basal ganglia that is impaired, like which is believed to be the reason for the motor symptoms, or is there other regions of the brain that you believed also to be affected?
Yeah, that's a great question. And I think something that we won't necessarily be able to get to the bottom to from this kind of population clinical level data. However, there is a fair amount of rich neuroimaging data there as well. We're definitely gonna wanna explore what are the neural correlates for the patients with Parkinson's disease that do develop psychiatric symptoms as opposed to those that don't and have purely motor symptoms. It's kind of roughly understood that there's actually seems to be subpopulations or what's called endophenotypes within Parkinson's disease. So Parkinsonism is kind of a broad umbrella. Within that, you have Parkinson's disease. And there seems to be different trajectories where some people have just a purely motor expression of Parkinson's disease. Other people have severe sleep disruption in addition to motor symptoms. Others have severe depression, anxiety. And actually identifying like what are those subclusters and how we can better categorize and provide kind of prognostic information for those patients is very much a question that we're interested in exploring further. As I mentioned at the start, we know that there's significant disruption of dopamine in Parkinson's disease. We also know that, for example, dopamine reuptake inhibitors can treat depression and can help with anxiety. And that is strongly related to psychosis as well. So these are all kind of the same systems, but yet we don't know why in one case, disruption of dopamine only manifests with motor symptoms. So there's still so much to be learned. So, yeah, thank you.
Hello, I have a question for Leanne. Hi, thank you for your presentation. I actually used to be a research assistant for the hotel study, mostly working on the hotel TBI study. So I was actually wondering, I'm not sure how separate the data sets are now, but if you had a chance to look at the head injury data in that population as well, and whether that was related at all to the incidence of suicide or suicidal ideation.
Unfortunately, I have not had a chance to look at that. Though because the TBI study was recruited from the hotel study, there are definitely participants within my sample that have had a TBI. So yeah, that's something to consider for future work, for sure. Thank you.
Also had a question for you, Leanne. I was wondering about the street drugs and alcohol in this population, and then I guess assessing some of the psychiatric symptoms. Do you have a way of controlling for that, or ask them about it?
Mm-hmm. So the way we collected the substance use data was through self-report of which substances did you use in the past month, going week by week. So in particular, we have data on methamphetamine use, opioid use, which at the beginning of the study, when it started in 2008, it was mostly heroin. And then increasingly, we've been able to see that fentanyl has increasingly entered that supply. We also have information on cocaine use and alcohol and tobacco and cannabis as well. And there is more granular data on dose, route of administration, and a urine drug screen as well to compare the results with. But for my study in particular, I just used the days of use. Yeah, just for sake of the statistics, but also in exploring that data further, I think that having more qualitative research and narratives from the participant sample would be helpful in informing some of the questions that we can ask and conclusions we could infer with that data. Yeah, does that help?
Yeah.
Thanks.
I guess we're getting to the end of the question period, and I'd also like to remind everybody to put the
lightning talk scores for both sets into Slido and then hit send. And the speakers will be around for both sets at lunch and able to field more questions. I also remind you to visit the posters in the poster gallery. And at 1:30, Dr. Claire Beasley is going to tell us about schizophrenia and the complement system. So we'll be back to that. And thanks again. And yeah.
So they two votes, writing courses for.
Okay. Should they vote for poster? Maybe they haven't seen them yet. I don't know.
You know, after they've seen it.
Yeah.
But they can vote.
Yeah.